Okay. Okay, thank you for reminding me. Okay, so I was talking about two kind of scenario maybe you will have in the exam. One, the patient may be quite present to you from beginning is in a cardiac arrest. You need to follow the ALS approach. Another scenario, maybe the patient is the unconscious, but maybe he has a sign of life, means non-cardiac arrest patient. So you need to follow the relevant the protocol like sepsis. You need to follow 6 sepsis. The bradycardia, you need to follow the bradycardia approach. So this way you can encounter like hypothermia. In hypothermia, there are a few stations which is mostly present is in a cardiac arrest. One is hypothermia. Okay. Another plus minus can be the anaphylaxis, but not at all. Is usually present is unconscious, but another is like I would say the drug overdose, like patient have taken overdose of calcium channel blocker. So this is a very common station. We have them, so we will discuss later. Okay, so the station types and approach, simple station. I just make it simplified for you, but you can use different ways. Anyway, simple station means the station you need to run in a single approach. For example, the patient came presentate to you, or a patient in Resus as the patient in GI bleeding. So you need to go with the GI bleeding protocol. Simply, once the patient is stabilized, for example, the blood pressure is stabilized after the start of the active transfusion protocol, and patient has been stabilized, and then you can hand over to the specialty. So this means simple station, which is just going single approach straightforward. But the same station, if it goes like, for example, presentate to you like GI bleeding, you stabilize this patient, but when you are going for the reassessment, the patient went to the cardiac arrest. For example, nurse will say, Dr. B, patient is unconscious now. Then you will say, okay, could you please check look, listen, feel, check the pulse, or maybe you can try by yourself with your hand, check the pulse and say, your patient has a sign of life. If you find the patient doesn't have the sign of life, that means patient is in a cardiac arrest, and then you need to follow the ALS approach. That means this station has dual approach and would be considered as a complex station. Clear so far? Did you get my point? It's a simple station and complex.
Yes.
Yeah, simple station, you need to follow either ALS approach and straightforward to, or the patient just a resuscitation approach and stabilize and hand over to the specialty. But in a complex station, maybe first you need to stabilize, and then maybe patient again go in a cardiac arrest, maybe due to reversible causes, is called the hypovolemia in this case. So in this case, the examiner want to test you both things, how you resuscitate the patient, but if patient goes to the cardiac arrest, what step you will take. And so both, you want to check you on both sides. So that's called dual approach. Okay. Now, the resuscitation approach, it's up to you what's easier to you to follow. I will never stress out, you must follow me. I would say there are different ways you can follow whatever look better to you, because it's your exam and I want you to pass the exam. So introduction, first of all, you get into the station, you need to introduce yourself and ask your team to introduce themselves to you. Okay. Second, then you need to ask them to prepare. I have the slide for that. I will show you how to what you need to prepare. Each different station have different protocol for preparation. For example, in upper GI bleeding, you need to ask your team to prepare also suction, but not every station need a suction. Okay. And there are a few more stations we will check out what could be the different, like in hypothermia, you need to prepare for the warm blanket. You need to prepare heat pads and also some other stuff to make the, also you can ask for the thermometer because this is relevant to that station. So preparation and also different special issue involvement, like you need to call, here you need to ask her to prepare following equipment and also call the ICU team, or if it's relevant, or cardiologist or cardiothoracic team, etc. Then you need to run the scenario. It depends what the patient present in what condition. You need to go with the assessment A, B, C, D, E, and then finding and then intervention. For example, in airway, the patient airway is not patent, then you need to ask, you need to go for a head tilt lift, okay? Or the patient is in, for example, there is a bleeding in his mouth or vomit in his mouth, you need to suction the airway, okay? And also you need to, similarly in B, for example, check the respiratory rate or the saturation is still low. Maybe if you haven't given the oxygen via non-rebreather mask, then you have to go for here to give the oxygen via non-rebreather mask. If you already given, still the respiratory rate is low, you need to go for the back wall mask, okay, etc. You need to take a relevant state. I also call the anesthetic. Another thing in B could be like in sepsis, especially, you need to order the when you or inspection auscultation, you find the basal crepitation or the crackles. Maybe you can ask the nurse to please do the X-ray for this patient. We have sepsis station. We will come up to that one. Then you will go for the intervention, as I said, the same. Then the last part is closure. And here you have two choices. I would say before hand over the team, you try to go for reassessment, okay? Go for reassessment, and then you hand over the patient to the team. Don't do before reassessment because you need to, I would say don't go if you still have time, because you need to stabilize the patient and then you have to go for the handover. Okay. 1 second, I need to admit the people. Okay, thank you. Okay, so it's clear so far here, guys. No any question here, right?
Yes, it's clear.
Yes, yes.
Okay, that's great. So let's come up to, I'm going for the cardiac arrest first, okay, ALS approach. Then I have written already everything. We just maybe read out and we will focus on important points. Okay, so this is the advanced life support. Whenever a patient you got in cardiac arrest, you need to go for this algorithm. For example, a patient brought into the ED, and I have table for that, and I will show you how we go, but I just want to focus on this, that you should, little bit information, you should get it before we go there. Okay, so patient is unresponsive. For example, patient is unconscious. Once you confirm the patient, then you need to go for the check for the sign of life. If you found the patient doesn't have sign of life, then you have to go for the CPR 30 to vent. In 30 compression 2 vents, and you, while doing so, you need to ask the nurse to connect the back wall mask and attach the defibrillator or the cardiac monitor. And ask nurse could be, if there is another nurse, ask that you should get the IV access, extract the blood. We have this station, we will focus on that. I will show you how we go. Anyway, once you set the rhythm, then you will see shockable. And what are the shockable rhythm? Can anyone tell me?
Ventricular fibrillation and pulses ventricular fibrillation, pulses ventricular tachycardia.
Okay, very good. So in the monitor, if you see that other than these two, that would be considered as non-shockable. Okay, if you found the ventricular fibrillation and pulseless we tag, then you need to go for the shock. Other than that, you need to go for the resuming CPR for 2 minutes, and after 2 minutes, then you will go for the adrenaline. Okay. The important point I want to stress out here is 4H and 4Ts. These are very, very important. If you don't go with them, you will lose your score. So the 4H and 4Ts, I'm going to show you here. 4H is hypoxia, hypokalemia, hyperkalemia, and also hypoglycemia. You can hear it. In hypothermia or hypothermia, hypovolemia, T for T, tension pneumothorax, tamponades, and thrombosis and toxin. So, for example, look at in this part first. Now you come up inside in the station, you introduce yourself, you got the introduction from the nurse, everything going. When you ask the nurse, is the patient conscious? First of all, you don't need to ask the nurse. First, what you have to do, you need to go the head of the bed and say, is the patient conscious? Means you need to touch if you can and check the patient is conscious or unconscious. Like, hello, sir. I'm Dr. B. I'm the senior doctor here. May I confirm your name? You have to do. So when you will do that, the nurse will say patient is unconscious. Okay. Then what you need to do, you need to check for the pulse, look, listen, feel. Okay. You look, listen, and feel. You will try to act like that, and maybe nurse will say in that time the patient is in cardiac arrest, no sign of life. Then you will ask the nurse, please start the high quality CPR. Okay, before going that, you can say, please call the ICU team or the relevant specialty and also anesthetic and start the high quality CPR, 30 compression tube and attach to the back wall mask. Okay. After back wall mask, you need to also ask her to connect the defibrillator pad and also connect the cardiac monitor. And also ask another nurse the name. When you will do introduction, of course, they will introduce themselves. So if you know the name, you will ask the nurse, please get the IV access, extract the blood for hematology, but better to verbalize full blood count, UNEs, the VBJ, and the other, like if it is in for example, due to sepsis or another maybe drugs if you suspect, or just verbalize toxicology screen, okay? Or if you want a CRP, if you can. And then you say, then you look at the monitor, or you can ask the nurse, what is the rhythm, what is the, or just check on the monitor. Better to check on the monitor because monitor will show you what could be the rhythm, okay? So if you found the rhythm, and then you check it, if you found it's shockable, like ventricular fibrillation or pulse rate retake, you need to ask the nurse to give the first shock and start from 150 joule, okay? And once the shock is given, then you ask the nurse, please resume the CPR immediately. Okay, so while she resumed the CPR, now you have to, and you need to verbalize, resume the CPR for 2 minutes. So once you verbalize the 2 minutes, then you will say, meanwhile, I continue my assessment, I will go for 4H and 4T. Please note that we have this station we will go for it in detail, but I just want to add some point here. So you said, meanwhile, I continue my assessment, I will go for 4H and 4Ts. So now when you will go 4H and 4Ts, now if the patient means this is a simple station, I mean, you haven't resuscitated already, right? Like it was in the tachyarrhythmia, means the patient has present to you as a cardiac arrest already. So in this place, maybe the nurse will tell you, doctor, I found following medication from this patient. Could you see that if it is a drug overdose? Okay. But in hypothermia is a different case. We will come up to that. But even if in hypothermia, then you will go for 4H and 4Ts. You will verbalize, I will go for 4H and 4Ts. Either if it's a drug overdose, nurse will give you the drug bottle, a medication bottle, maybe medication box. She will say he has taken this medication. Then you understand why his condition is like that. Then you will say, okay, I will go for 4H and 4Ts. Hypoxia, we are managing with the back wall mask and high flow oxygen. Okay. Like here, I would say, show you here. Hypovolemia is less likely in this case. Is a patient has no bleeding, no trauma. You need to rule out hypothermia. Nurse, could you please check the temperature for this patient? Nurse will check it. Okay, temperature normal. Okay, so no hypothermia. That means, and then you will go for hypo and hyperkalemia. You say, we are waiting for the blood results. I'm waiting for the UNEs. Do we have the blood result? Or VBG result. If you got the VBG result, then you have to comment. If no, then you will move for the next. Tension pneumothorax could be less likely. You need to auscultation, auscult the chest to clear the lung fields in this place, and you need to rule out. If not, for cardiac tamponade, you said, we will do a bedside echocardiogram. Could you please done it now? You ask a nurse. Next is toxin. So, of course, if patient has overdose, then you will have to comment, yeah, it's likely the patient has taken overdose of calcium channel blockers. So it's likely the cause in this patient in a cardiac arrest. Please, nurse, then you go for the action. For example, the antidote, okay, like calcium chloride, calcium gluconate, we need to give. And the CCB channel blocker, I mean calcium channel blocker, then you have to ask a nurse to give the antidote and also the fluid participation in bradycardia. Okay. So after that, you finish this 4H and 4Ts, then you will say, ask a nurse, has 2 minutes passed? The nurse will say yes. Okay, so that means that 2 minutes passed, and you will ask her to assess the rhythm. If the rhythm is the same, then you go for the second shock. And this way you will go for the LS. And finally, so the examiner in cardiac resuscitation want to test you in important thing. First, they want to test you how your approach in once you got the cardiac arrest patient. Second, they want to test your knowledge at 4H and 4Ts, that how you rule out the cause and to reach the reversible cause, what is a cause, and how you deal with that. So these are 2 important points which the examiner wants to test you in a station where the patient present to you as in a cardiac arrest already. Clear so far?
Yes.
So did you understand how to go with the 4H and 4Ts? It means you need to rule out the causes. Okay? Hypothermia, you need to go ask the nurse, could you please help me to check the temperature of the patient? Okay, temperature normal. That means you have to rule out. So it's not the cause of the cause of the condition of this patient. Then you go for the tension pneumothorax. Then you auscult the chest of the patient and say, okay, the echo, there is entry of the ear. So it's not the cause of tension pneumothorax. Then you go for further T. Okay, like for example, if the patient is cardiac arrest in acute coronary syndrome, then you say it's likely the cause of thrombosis. If the patient is in cardiac arrest, so you need to ask the nurse, please activate the cath lag or etc. You have to take the step or thrombolysis. Altiplase, you need to give this patient if in case don't have the cath. I mean, cannot perform the PCI. Okay. We have this station we will discuss in detail later. So I just want to tell you how you can rule out these things and reach the reversible cause and deal with this reversible cause. And finally, the patient will be stabilized. Then you will hand over patient to the relevant specialist. Okay. Now let's, okay, do I need to go with that? Hypoxia, okay, you will, patient airway should be maintained and optimize it, the oxygenation for the patient. So you will say, yeah, hypoxia is managed here with the high flow oxygen. Hypovolemia, if you give the fluid already, so you said we are managing with the fluid, with the blood, etc. Or you can say, likely the patient is hypovolemia because a patient is traumatic or a patient is bleeding, or less likely because patient is not bleeding, patient is non-trauma, patient doesn't have any trauma. Like that, you need to rule out hypothermia, ask a nurse to check the temperature if not already. If patient is cardiac arrest after, is in the complex station, already you resuscitate, already you went to the E where you check the exposure, means you went for the temperature. So you need to comment here, yeah, I found the patient temperature is normal, so it's less likely to cause. We will come up to that one later. Okay, so I have written the research general approach. So the introduction, once you get into the station, you will go for, hello, my name is Dr. B. I'm one of the senior doctor working in this emergency department today. May I confirm your name and your role and your grade, please? Means all together, your role and your grade. In role, she will say, I am the grade. Maybe she will say, I'm Alice provider, I'm Alice. I provide Alice support, and also she will say a role is, or maybe she say I can manage, I manage airway. Maybe she can say I'm in circulation, or I am providing another support. Maybe she will say, or you will ask your team, could you please introduce yourself to me? Okay, this is much easier if you say like that. Once you come up to the station, you introduce yourself, then you ask them, could you please introduce yourself to me? And please, you must tell me your grade, your role, okay? And then the nurse will say, yes, my name is blah, blah, I'm Alice provider. My role is this, I can manage airway. Once you know the name, and then you give the task accordingly. Okay, so once you got their name and grade, then you don't need to ask the nurse, or you Alice provider, or you etc. Better to give them a chance to talk. When you will ask them to tell their role and their grade, they will tell you by themselves. Okay, so once you got it, then you have to go for the next step. Like, okay, so we are expecting a patient, or we have received the following pre-alert. A 30-year-old male is coming by ambulance soon, and he is bleeding, okay? For example, upper GI bleeding, I take an example here. Please call the ICU team, or you can say, please call the ICU team and also the anesthetic. And apart from that, please also call the gastroenterologist. Patient may be required the endoscopy later, because upper GI bleeding, anyway, you don't know if it is non-varicose, so patient require the endoscopy before you go for the PPI. So you must know the treatment of both non-varicose and varicose. Okay, please call the following team, and then you will go for the role, for example, manage airway. So nurse A is managing airway, for example. So you say, nurse A, please, could you please manage airway? If she said, yeah, I would do, then you say, please prepare following equipment: suction, oxygen, and the airway trolley, or difficult airway trolley you need to mention. And also for breathing, maybe you can ask her to pulse oximetry or the monitor, etc. For the circulation nurse, you would ask, please prepare following commands: the IV access, fluids, defibrillator, or the cardiac monitor, BP cuff. Very quick to verbalize. I already write it down here that you can pick up, okay? And prepare following things. Once, and please now wash your hands or put on your PPE. If you don't ask to wash your hands, just say wear PPE is okay. Okay. Once you ask this everything, and then you need to, one more thing is here, you know that the patient is bleeding, you also need to ask the nurse, in circulation nurse, which is better to ask her to send a pre-alert to blood bank. Patient will record the blood, or you can say activate the transfusion protocol. ask a nurse which means the circulation, or you can verbalize it in while you say, please call ITU team or the gastroenterology and the anesthetic. So after that, it's clear here, right? Introduction and preparation of ICMA.
Yeah.
Is there any question you have?
Yes, doctor.
Yeah.
Can I ask?
Yes, yes.
So if they've given you 2 nasals and you assign one to airway, you assign the other one to circulation, who do you assign for the defibrillator? So how do you need that?
Circulation
They
nurse.
only give you 2 nasals.
Circulation nurse will take over. Okay. But is it clear? I mean,
Yes,
usually.
So if you are in the scenario, who does the CPR? Who does the defibrillation? If you have 2 nurses only, one is in charge of the airway, one is doing CPR. Who's in charge of defibrillation? If you only have 2.
If you have the other nurse, they will take over. If there is any other nurse, then any one of them will take over. Because they both would be the LS provider, they must have training on it. Okay, so it's not a big deal, but you just need to ask the equipment, and the rest of things, when you verbalize, they will take over by themselves. Okay, so defibrillator, you can ask this old nurse, the circulation already it. You need to ask her to make it ready, and also. One more thing, when you ask the equipment ready, you must ask them to make sure these all equipment are working properly. I have next slide, we will discuss on that. Okay, so here the equipment is ready.
Sorry, I have question.
Yeah.
Regarding airway preparation, shall I verbalize all the equipments? Like I should ask for airway trolley, oxygen, suction, saturation probe, and back valve mask, AT tube, thoracostomy, all of that. I should verbalize it.
Not
or
all.
Shall I just?
No, listen. Not all of them. The relevant. For example, the important one, like very quick. Use a suction, suction, oxygen back valve mask, and airway trolley. That means very short to go. Means you need to verbalize a few of the equipment. Okay, in difficult airway trolley, these all accommodate. But I mean, if you verbalize a few of them, that would be better, because sometimes nurse asks you what equipment. Well, then what you will answer. It's better to don't give the chance to nurse to ask you what equipment. You need to verbalize, because the equipment will be in front of you. When you come up to the station, the equipment will be just in front of you. And then you will see that what equipment are they. Okay, you just need to verbalize that you need to prepare these like oxygen, suction, the airway difficult trolley, and also the pulse oximeter. It means very important one. Pulse oximeter is very important. So you need to ask them. Oxygen is very important. Suction is very important in GI bleeding. So you need to see the station which is relevant. For example, if you talk about hypothermia, the relevant here equipment can be the blanket or blanket heat pads, the relevant thermometer, low grade. So these are relevant, right? And so you need to ask these to prepare these all equipment according to the station.
Dr. G, can I ask you a question?
I think you guys are going to have too many questions, so we will go very, very slow. Anyway, you can ask quick. This is the last question. Then we will give you. I will give you a chance to ask me.
Yes. So if you have a patient, drowning patient, so do you have to ask from the introduction just to prepare maybe the bug hugger, maybe also the all the passive and active, the active rewarming materials and equipment?
Yeah, I said I have written these all stations separately. I will come up to you. Okay, I will show you how I make the hypothermia station. You will check it out by yourself. Okay, I have written everything for you. Then you just go over. Okay, let's come up to the position now. The airless, or I mean, the resuscitation station have two kinds. Sometimes they mention you that you have a leadership role, but if they don't mention the leadership role, then you have to do by yourself, unless the nurses stop you. For example, now, when you come up to is a patient here? Is a patient all right? Yeah, patient is here. Okay, then you come over the bed of the patient and, hello, sir. Hello, my name is Dr. B. I'm the senior doctor here. May I confirm your name and age, please? The nurse will say patient is unconscious, or the patient is conscious, or the patient will, the nurse, if is the patient is talking. If patient is unconscious, then you ask, then you check for the look, listen, feel. Is a sign of life. You have to do. If the nurse say, sorry, I'm going to do, that means you have to stay away from the bed, in the end of the bed, and you need to verbalize the things and let them do. Okay? Did you get my point, everyone? I mean, you don't need to think that every station you're a leader. You have to do by yourself if you have any doubt, unless the nurses stop you. Once nurses stop you, you need to go to the end of the bed, and you just need to verbalize, and the nurses will do their action. Clear?
Yes, it's clear.
Okay, that's good. So, if you come up on the bed, the patient is unconscious, and but the patient has sign of life, then you will ask, okay, please apply the high flow oxygen at 15 liter via non-breather mask. Okay, so for example, unconscious, so no sign of life, airway, you saw the patient. Oh, sorry, I skipped the thing. Is the airway patent? No. Please follow head tilt. If the patent, you just apply the high flow oxygen. But in upper GI bleed, of course, maybe if the case is upper GI bleed, and when you ask is the airway patent, the next step would be your if the nurse say no, so nurse will say no, there is a vomit or the blood in his mouth. So what you will say, nurse, please give me the suction. We need to suction the airway. Give me suction, or you say, please hand over me suction. You need to get, because I remember when I gave the example a long time ago, I did suction by myself. I mean, I asked them to give me suction. It wasn't connected. There was even no tube, connected tube. It was just suction equipment in my hand. And I did it. I just showed them, and I run all the station all myself. But it's not always the case. Maybe you need to run the station different ways. I mean, you will be as a leader, and you're leading the trauma team. Okay, so after suction, whatever now is your patent. Yes, please apply high flow oxygen with via non-rebreather as the 15 liter. Okay, but now my question is that, guys, if the patient, any station, I'm not talking about the upper GI. If the patient, the patient is talking, what is your state?
I'm happy with the airway. That means the airway is patent.
Please open your mouth there. I can ask him.
The window.
Okay, so and now the patient is talking. Yeah, so you have to be happy with the airway because patient is talking. You don't need to apply any oxygen. Okay, then you will go for breathing. So now I want to ask you a question. Now, you know the airway is patent. Now you are in the breathing, or I mean, you are moving to B. What your state would be if patient is talking?
Now we will just look at the partial pressure of oxygen, and we'll auscultate the chest, and we'll percuss the chest. Okay. And we'll note the respiratory.
No, the guys, you're a little bit, you know, just I want to ask you one question. The patient is talking in real time. You have real patient, not talking about this mannequin, but the real patient is talking. Patient is brought into the ED, and you're happy with the airway. Now, but you know the patient is talking. So when you're moving to the B, what you have to do? you need to
connect the monitors and check the saturation and respiratory rate.
No. Okay.
Give oxygen.
This you need to ask the nurse. Okay, please. Expose the chest, connect to the monitor. But for the exposure chest or anything, for example, you can ask a nurse, please use the pulse oximeter. 1 second, please. You ask a nurse, please use the pulse oximetry, attach the probe, and check for me the oxygen saturation and respiratory rate. But when you will go for the chest inspection, palpation, and the percussion and auscultation, you need to take a consent from the patient because the patient is talking to you. Then you say, "Sir, I'm going to look, feel, and touch your chest. How's this sound to you? Is that okay to check out?" And the patient will give you consent. Okay, and then you will go for the exposed chest and go for the palpation, inspection, palpation, and auscultation. Otherwise, you don't have to touch because the patient is conscious, right? You need to take the consent if you can. So that means that you're more professional. So if a patient is talking to you, better to talk to the patient, take this state. If patient is unconscious, not responding, or the patient is unconscious, not talking, then you need to take the state, etc. No problem. But it would be grateful. It will help you to get a good score if you take the consent. If patient is talking for each step, for example, when you come up to the circulation, or even you start of the station, I have the sepsis station. I will show you how we deal with this kind of patient. Okay. So
if patient is talking, no need to apply oxygen, or we should apply oxygen.
No oxygen.
No oxygen.
Then it depends on the B. It depends on B. You will check the saturation. You will check the respiratory. Respiratory rate is low. Oxygen is, for example, respiratory rate is high. Oxygen saturation is low. Then you will ask the nurse, please attach the non-rebreather mask and give the patient high flow oxygen at the 15 liter. Okay, so you need to verbalize here. But if it's still not, if there is a problem, the respiratory rate is low, okay, and oxygen saturation is low, then you need to go for the back wall mask. What is the indication of back wall mask, guys?
Low GCS.
Okay, this is
bradypnea. Bradypnea.
Respiratory rate.
Times 12.
Yes. Respiratory rate is less than 12. Oxygen and saturation less than 92. So in this case, you need to go for the back wall mask. Okay, but different patient is not indicated in the COPD. Don't make mistake this one. Okay, because we need to maintain the 88% of the saturation to 92. So that's a different case. Okay. Note the oxygen saturation, and from here, if any parameter is below the normal, an intervention is required. Means you will ask the nurse to give the oxygen, means a non-rebreather mask, apply high flow oxygen, and then you will go for the lungs field. Now I divide in two parts, but it depends. It's up to you. If you want to divide in two parts, or if you want to go in single, but I would say the better to go in two parts, because if it's not attached to the monitor, you would say, now let's connect A and B. For example, in airway, you found the patient is talking. Now you will say, nurse, under Katie, this nurse, or we have found the patient is talking. That means I'm happy with the airway. Airway is patent and it's okay. Now let's move to the B. And could you please help me to attach the pulse oximeter? Or you would just say, could you please check the respiratory rate and oxygen saturation for this patient? Meanwhile, I'm going for the chest inspection, or meanwhile, I will go for another assessment. You can say in short, and then you say, please expose the chest of the patient and connect to the monitor. If you don't connect monitor, no problem. So in palpation, now let's come up to the inspection. You inspect the chest if there is rash, any deformity, etc. What about the palpation? What would be your step in palpation, guys? What you will do?
Chest expansion.
Very good. Chest expansion. And the important point, another one.
Percussion.
I'm talking about the patient. Trachea. Very good.
Trachea.
You, as I said earlier, if you need to do the station, you need to run the station, you have to use your 2 fingers, okay, to check the trachea. Is central or not. Clear? And then you will use your hand to check the expansion. Just act like that, okay? Act like that. And then you will go for the percussion quickly. If you need to do, then you will go for quickly percussion, and the nurse will tell you. For example, in sepsis, the nurse maybe says, I mean, in pneumothorax, maybe the patient, the nurse will say hyperresin, etc., like that, okay? Or she will say it's clear, because nurse will verbalize after you when you are doing the action. Okay, once you finish these, then you will go for auscultation, and auscultation will help you in the lung sounds and the heart sounds. I would say that if you do heart sound in circulation, but if you do in this B, it's also okay. Would be better to do the relevant thing in relevant place, like in circulation, if you can. If you don't do, then you can do in B as well. It's no problem. Okay, so lungs fill sounds. For example, if the patient has chest infection, you will find the basal crepitation or the crackles. If clear, then you will go for the C. Okay, now you found the respiratory rate is low, oxygen saturation, respiratory rate is high, oxygen saturation is low. Now you ask the nurse to apply high flow oxygen via non-respiratory mask. Okay, good. If you found the crackles, excuse me. Okay, I'm talking about if you found the crackles, for example, in sepsis. So what would be your intervention? Okay, you apply a high flow oxygen. Okay, good. You give, and now you found the crackles on the chest. I mean, auscultation. What would be your
Chest X-ray?
Chest X-ray.
Septic shock due to pneumonia.
No,
Do you get furosemide? Lasix?
Yes, you need to ask the nurse, please take the arterial blood case, ABJ, and do X-ray as soon as possible and give it to me. Clear? This action should be taken in B. Now, your question must be raised, well, and the large bore cannula could be applied in C, but why in B, ABG? ABG doesn't require all cannula, you just directly do it. You don't need the arterial blood gas cannulation. Did you get my point? You're not going to give forward, but you need ABG as soon as possible based on patient is crackle.
Excuse me, just can you repeat it again?
I'm talking about this in the sepsis station. I mean, if you found that's what I say. Whenever you find any abnormal things in B or C, you need to take the intervention on that place. I mean, action should be taken in that place. So, for example, you found the patient has the crackles, you don't need to say the patient has pneumonia, still you're not confirmed, okay? Patient is the crackles, so you need to find out what could be caused. You need to go for the X-ray, right? And you need to go for the ABG to check. What you need to check in ABG, guys? You need to check. You need to check here, is it type 1 failure or type 2 failure? Okay, this can help you that whether this oxygen alone will help or not. Okay, but in pneumonia is very, very common. It's type 1 failure and not type 2. Clear so far? I think it's very complex, but don't worry, I have sepsis, the same table, everything is written. You just, if you got the station, I think you just memorize and verbalize it. It's okay. I have written everything for you, don't worry. Okay, it just means that the intervention you need to take where you find the abnormalities, okay? Okay, let's come up to circulation. In circulation, what you have to do. One more thing I want to highlight. If there is already cardiac monitor attached, so you need to check the parameter on the cardiac monitor, not to ask everything about the nurse. For example, and now you ask the nurse to attach the cardiac monitor in B, so it might be already attached in C. Patient already on the cardiac monitor. I mean, the monitor is attached, so vital can be checked out on here, right? Now you say, if patient is unconscious, and then you will go for the ask the nurse. Okay, now let's. I'm moving to the circulation, or let's move to the circulation. Nurse, could you please help me to check out the blood pressure of the patient? Okay, and I'm going to check the CRT. You are going to check the CRT. Okay, better help together means one thing you give her the task, another thing you should do by yourself. Don't need to ask the nurse, can you help me to check out the CRT? No. Better. You say, could you please help me to, you say, could you please help me to check out the blood pressure and heart rate of the patient? Maybe the nurse will say, you please look at the monitor. As I remember, the nurse said me, look at the monitor. She said on the monitor. She verbalized it. She said, look at the monitor. That means I need to know everything from there. Once you know, the nurse said you to look at the monitor, then all interventions, C or B, all things, all interventions should be depend on the monitor. Means you will check on the monitor and ask for the action. Okay, so once she says look at the monitor, if you found that blood pressure is low, etc., heart rate, everything will visible, and you take the action. About the peripheral pulse, or you need to pulse do by yourself. Okay, so the peripheral pulse you need to check by yourself with your 2 finger, which is feasible for you from the radial, or you can check the other femoral. And the CRT you also can do by yourself with 2 finger on the sternum. It's much more easier. And then you can see, and the nurse will say, oh yeah, it's 2 or less than 2. But if you don't do, you just say, could you please help me to check nurse, whatever CRT? That's impolite, and this is not right. I mean, it would be better you do, now I'm going to check the CRT, put your finger, the nurse will say it's 2 or the greater than 2. Okay, so clear so far here? Do you understand what I mean to be? Means overall, the conclusion is that you don't need to ask everything nurse to do. You need to do by yourself, okay? If you give one task to check for me the blood pressure and the heart rate, the rest thing you need to do. Means you need to peripheral pulse, you need to check and go for CRT, you need to check the CRT, and the nurse will comment, okay, doctor, CRT is 3. But if you have the leadership role, you need to stand the end of the bed and just order on, ask a nurse to do everything. Do you understand,
How
guys?
would I know if I have the leadership role?
Yeah, this is just now I said, when you come up the station, for example, patient is, when you come up the station, you introduce yourself, you need to go the head of the bed, the head of the bed, and for example, patient is vomit in his mouth, and you ask the nurse, please, can you give me a suction? Before you go for it, you need to go for the reassess patient. Is the patient conscious? Then pretend to use like look, listen, feel. Yeah, there is sign of. Nurse will say, when you pretend to do, nurse will say, yeah, there is sign of life. Then you will go for next action. Okay. Here,
I know that I have the leadership.
Yeah, here maybe nurse will say, for example, when you suction, nurse will take over. That means they have to do. You just need to verbalize. Then you have to go to the end of the bed and you verbalize the things. But if nurse asks you,
end of the station, I will be at the end of the bed, right?
Yeah. If you're the leader, you will be end of the bed. If you are performing the task, then you have to do. You have to do. That means if the nurse asks you to do, means you have to do. Sometimes the nurse say you to do. Even on the case outside on the station, they have written, you need to assess and manage this patient. That means you have to do, and they will be your helper. Get it? I would say the 70 to 80% station, most of time I found these all are you have to do. Okay, most of time you have to do, unless the nurse say you please, I'm going to take over, or first maybe you need to do, and the nurse will take over. For example, you're going to start the CPR, the nurse will say, okay, I'm going to start it. And then you need to go to the manage the airway. I mean, you need to hold the back wall. Sometimes, what I heard in Malaysia, one candidate, he gave an exam in Malaysia. He said, when I asked them to attach the back wall mask, and they said to me that we don't know how to do that. So what they want from him, can you tell me? They want from him to do first, and they will follow him. Clear?
Yeah, it's clear. So for any action, we have to proceed as we are doing. After that, when they will stop us, we can be as
yeah,
leader, right?
you can act like a leader, or you can need to take both part. I mean, first of all, you should show them to do, and then if they again second time, or if they ask you, doctor, we are going to do, you just say so. You're a leader. If they mention you in outside in the station scenario that you're a team leader, then you're a team leader. You don't have to do anything. You just need to say. But if they're not mentioned, better to start by yourself. Okay, you need to take over everything. You do CPR first, they will take over. You do suction first, they will take over. You need to inspect the inspection of the chest. Means you need to pertain to do that. Okay, mannequin on the mannequin, just like you are doing in real time. Clear? Yeah, but don't be mistaken that you are the team leader. Every time you go in the station, you just say, ask the nurse, okay, please do that. Please apply full oxygen. Okay, what is the blood pressure? What is the CRT? You're going to ask her everything, but it's wrong. You need to do by yourself. First you do, then they will answer you that the CRT is less than 2 or 2, because the camera, if camera is, because there are two kinds of assessment of your exam. First, the examiner sit in while you're doing. Another is recording. They will watch you out, or they will hear your voice. Anything like that. It depends. So if you do the action, that means they will think like that you are doing every day, and you're experienced about it. But if you just stand like a robot, that doesn't make sense. Okay? So always, my advice to everyone, always first you take over, then hand over, means start CPR by yourself, and then give to nurse will say by itself, okay, the doctor I want to do, then you get hand over. Okay, so the similar, so the vital parameters is you need. Could you please help me to check out the blood pressure and the heart rate? So the nurse either will say you to check on the monitor, or she will tell you, verbalize you, and then you have to say, meanwhile, I will check his pulse and also CRT. You need to mention that what you are going to do too, okay? Because it's not like you say to her and you just stand. Stand is not a good thing. You should do peripheral pulse, check the pulse, CRT. But if leadership role, don't do that. If it's clearly mentioned in this, in the case. But I don't think so. Leadership, not all the time. Very rare to come on, I would say. When I encounter, or my colleagues encounter, they said they have done. So, I mean, it's more likely you have to do. Okay, so now you found CRT, everything, then you have to go for action according to. Please enter to lower peritoneal extra blood, full blood count, VBG, cross match if patient is bleeding. And I forget another one is here is UNEs. It's very important. Okay. And toxicology screen. Other investigation is depends if it's a tachyarrhythmia or another things. Get the ECG as soon as possible. We have the slide for that. We will come up to that one. After that, you need to verbalize the finding to the nurse, i.e., it's a bradycardia. Please follow the bradycardia algorithm like you need to ask the nurse, please give the patient is atropine is 0.5, the 500 microgram, okay, 0.4 the mg, or the 500 microgram, and repeat it every 5 minutes, maximum to 3 mg. Meanwhile, also attach the pacing tape to this patient, because maybe patient will go refractory bradycardia, or maybe patient requires second line intervention. So you need to verbalize. You have to follow the algorithm. Okay. About GI bleeding, I have separate. I will show you how we intervene. Then you will go for a check for the patient level of consciousness. If the patient is conscious, as I said, the patient is talking, then you have to go for, I have another slide. I have written 3 questions. Like you need to go for, ask the question. Hello, sir. I have a few questions to ask you. Oh, is that okay? Okay. Could you please tell me what time, what date is it today? Like you need to ask about time, about the place, like where are we now? This is called you're checking in case the patient is conscious. Not about the unconscious. I'm talking about the conscious and patient's talking. Then people like to reflex you have to do by yourself. You need to use the whatever in your hand have. You just need to apply and check the pupil. And before, I would say, before going for the check level of consciousness or the pupillar reflex, I have second slide. I have written it very clearly, but I want to verbalize here too. You would say, the nurse, could you please help me to check the blood, patient blood glucose level? Because it's nurse to do, right? Not you. Could you please help me to check the patient sugar level? Meanwhile, I go to check the level, conscious level of the patient. So you will go for the check, for example, or if you think patient unconscious, then you need to ask the patient GCS or try to check it. And also use the light reflex to check the pupillary light reflex. Once you're done, then okay, I see the patient is conscious. Okay, pupils are equally reactive, and the blood sugar level, could you please tell me? Okay, the nurse will say, yeah, 5 millivolts. Okay, I'm grateful with that. Now let's move to the EE. Please expose the chase the patient completely. Then you will try to pull the hand of the patient, check the rash if the patient has it, any swelling on the body or anything else, you have to check it out. And also you need to ask the nurse, again, you need to ask the nurse here, could you please help me to check the temperature of the patient? Meanwhile, I'm going to check another abnormality of the patient. So this verbalization is very important to get in touch with your team and communicate with your team. So this is how you can go for A to E. Clear so far, guys, here? Don't worry about the station. I have written separately. We are coming up to that one. After that, you need to hand over. This come up to closure, means ongoing care. Reassess the patient. Whether if you have good time, you think you are very fast, and you have still time, then reassess the patient would be better. But if patient go again, and while you're doing reassess, as I said, if into patient cardiac arrest, then you need to follow the LS protocol. So this is general approach about the resuscitation in adults. Now let's come up to the important one. Similarly, I have written the resus in upper GI bleed. Okay, so let's come up to the resus in upper GI bleed. Again, same introduction, same everything, you have done it. But one thing, get team to resus. Which team you need to be in resus? Gastroenterologist, anesthetic, okay? Because patient may require intubation in upper GI bleeding. So you'll say, please call the gastroenterologist, and anesthetic is the patient may require intubation later. So this is how you need to say. Then you will go for the equipment, suction, oxygen. And for the nurse in circulation, you need to send a pre-alert to the blood bank, or you would say the active transfusion protocol. The similar on all station, as I say. And then you will go, if you're going to leadership role, you have to stand of the bed. If not, then you have to go to the head of the bed of the patient and check it. Is patient here first? Make confirm. Is patient alert? No. Unconscious? Please check sign of life. Usually in upper GI bleeding have the sign of life. They don't give the patient which doesn't have sign of life. They usually give the patient which has sign of life. And even they can give you a patient is talking, can be possible. It depends. So here you will go for the airway. Then you have to go, is the airway patent? No, or there is, maybe the nurse will say there is a blood in the mouth. Then you will say, okay, please suction the airway and give me a suction. I need to suction the airway. Maybe the nurse will say, I do. Then she has to take over. Then you, okay, meanwhile, I'm going for, you have to verbalize. Meanwhile, I'm going for another thing to manage, or you have to say, suction the airway now. What about the airway? Is the airway patent? Okay, airway patent now. Apply the high flow oxygen with the 15 liter and a rebreather mask. In case patient is not talking, patient is unconscious, and then you have to, and then you have to go these all steps. So just give me 1 second. I have a call. Okay, I'll get back to you. Okay, so here we need to check the airway. Airway is patent, so you need to go for oxygen. Okay, so usually, as I say, the patient patient always have sign of life. His station still now has came in the RCAM, so you don't have to worry. It's a straightforward question, but you have to you need to be master. I would say you should be very familiar with the transfusion protocol, which is very important in this situation. Okay, so is the airways. Okay, so let's move to the breathing. You need to verbalize to nurse. Let's move. Guys, we have to move to the breathing. Could you please help me to check out the patient respiratory rate and oxygen saturate? You need to say to nurse, could you please help me to check out the oxygen saturate? This is called the way of communication. Again, don't say like, what is the oxygen saturation? Was the respiratory? No. Could you please help me to check out the patient oxygen saturation and respiratory? Maybe she will use the pulse oximeter. Maybe she will take the monitor. It's up to her. So, but anyway, she will tell you what's the respiratory. So if you found the patient require intervention, if you haven't applied the high flow oxygen, maybe patient was alert in that time. So now you have to apply the oxygen. But if she said, yeah, it's normal, you found the respiratory rate is 16, 18, or the saturation 92, above 94, 94%, so you don't have to apply anything. But if again is less than the normal and respiratory rate is low and oxygen saturation low and patient need, and then you have to ask to apply the back wall mask to the patient and call the anesthetic. Patient may require intubation later. Okay, so you need to verbalize that. Okay, after that, you need to expose the chest of the patient chest and do inspection. 1 second, it's a bit noisy here. Okay. Excuse me, I heard some noise here on me, so it's okay. Thank you. Okay, again, so the patient oxygen saturation, as I said, the low in respiratory low, you need to ask the backflow mask and call the anesthetic. After that, if patient is talking, as I said, you need to take the consent. If not, then express chase, you connect the monitor, you need to inspection, like you need to check the trachea central or not, you have to do. Also the chest expansion with your 2 hands to check. Then you have to go, palpation, I'm talking, inspection, you will just look over. Palpation trachea, need to check the trachea position and also the expansion of chest. After that, you need to go for percussion. And then the end, you will go for auscultation. So you won't find any problem here. The problem would be here in the circulation. That's very, very important. So now here what you have to do, you need to ask, nurse, the name, if the name is Nurse Katie, like, or the Lisa, or the anesthesia, or any name of the girl, Bendy or anything, say you need, could you please help me to check the patient blood pressure and heart rate for me? Thank you. Meanwhile, I go for the check the patient peripheral pulse and CO2. Okay. And then while you're doing so, the nurse will verbalize you, the CRT is this, peripheral pulse is weak, or what else. And then you will go for intervention. Then intervention nurse, could you please pass it to large bore cannula to this patient and extract the blood, full blood count, the BPJ, cross-match, toxicology screen, and UNEs. Okay. Okay. Then the finding, okay, I'm seeing the patient has low blood pressure and heart rate is this, blah, blah, blah. And the patient is tachycardia, he has sinus tachycardia, etc. Peripheral pulse is weak, CRT is this one. Nurse, please activate the emergency transfer in Portugal if not yet. Because the bleeding, if you find any patient is bleeding, you need to, at the beginning, you always need to call the relevant specialty or any blood bank alert, as we already discussed. So you need to say in early as possible when you start the stage. So you need to confirm. If you haven't send the pre-alert to blood bank, could you please do it again? And also, then you go for the blood, do we have? So what is the criteria for the blood transfusion, guys? Anyone can tell me?
Resuscitation area?
Yeah, criteria for blood transfusion.
Resuscitation area?
Hypotensive?
No.
Excessive loss.
Heart rate.
Stroke rate 3 and 4.
Heart rate.
Stroke rate 3 and 4.
Heart rate greater than 110. Respiratory rate 30. Okay. These are the criteria in hypertensive systolic blood pressure less than 90. So
criteria, I thought it's area.
Oh, what? Excuse me, what did you say?
No, you said criteria. I thought it's area.
Oh, I'm sorry. Okay, so is my sound is clear to you guys? If you have any problem, you can stop me and ask me to correct it, okay? Okay. Okay, so after that, okay, so you ask a nurse, could you please, now, not only about the transfusion means you need to go for all blood, negative all blood, but you can also give the fluid bolus, no problem. There is no any problem with that if you give the fluid. That's okay if you give the 500 boluses, no problem, but not more than 2 liters. This is according to NICE guideline, but you can give. So you can ask a nurse to, do we have the cross-match or the O negative blood you need to start? And ask a nurse to also give the tranexamic acid 1 gram in 10 minutes. Consider not every time. If you could give, it's good. So in 10 minutes. And also, please prepare the primary transfusion pack, which include 4 RBC, 4 FFAs, okay? And also the plus minus platelet. Okay. Is clear so far here in circulation?
Yeah, it's clear.
Okay, good. Now, if it's non-varicose bleeding, okay, now how would you know it's non-varicose bleeding or varicose? So it's possible in the case what you will have, if they mention the alcoholic, it's a likely varicose, so you need to, if it's not varicose, then you need to ask, in both cases, you need to call the gastroenterologist, but here especially, in non-varicose, you need to verbalize again because patient require endoscopy before you go for the PPI. I mean the proton pump inhibitor. So if varicose, if you found it's the varicose bleeding, then you need to ask the nurse to give terlipressin 2 mg and also antibiotic subtractor. Okay. Okay.
Sorry, so Dr. B.
Yeah.
Are we supposed to give tranexamic in APOGEE? The varicose, non-varicose. Are we supposed to do
Excuse me, I cannot hear you. You have.
Are we supposed to give the tranexamic acid in upper GI bleeding? Whether varicose, non-varicose, are we supposed to?
Yes, is usually what you recommend according to guideline is less than 3 hours in trauma, but you can give in, you can consider in any bleeding. You can consider any bleeding. It's not necessarily, but you can consider. Okay, there is no any guideline would say contraindication, so I cannot stress out this contraindication. Okay.
And for non-varicose bleeding, can we give PPI also?
Non-varicose bleeding, first you need to do endoscopy. That's why I added here in the step 3. You need to ask the nurse, is the gastroenterologist here? Did you call the gastroenterologist? Please call it patient require endoscopy. It's very urgent. Okay, it's very urgent. According to NICE guideline, the endoscopy should be done. Okay, as soon as possible. A patient has non-varicose bleeding, so you need to ask. But in varicose bleeding, you can also need the endoscopy, but in 24 is not required at the moment. So it's not very urgent, but it's still required. But after it can be done after the stabilization of patient. So if it's varicose, so you need to ask nurse to give the 2 mg terlipressin and store the antibiotics. And apart from that, you will nurse ask if would possible please insert the NG tube. This is very important. You must need to insert the NG tube and also urethral catheter. Okay, you need to ask a nurse to do. And now, sometimes when people are discussing, for example, you give the terlipressin, you give the antibiotic, or even you didn't give, I tell you another way to accommodate these all things. For example, you give the patient tranexamic acid and the O negative blood, but you didn't give this terlipressin antibiotic. So when you have to give? Another way to give is here in the end after E. on a discussion. For example, based on my assessment, this patient has upper GI bleeding, and that is, he's alcoholic, so it's likely a variational bleeding. So here I want to prescribe this patient 2 mg terlipressin and start on the antibiotic 1 gram ceftriaxone. And it would be possible if nurse, could you please insert the NG tube and urethral catheter? Okay, thank you. Meanwhile, I'm going to reassess the patient. Now let's reassess. So you have two choices. Either you say in the C these things, if you don't want to say, so come in the E. Okay. What look better to you, you need to say in anywhere in between. I mean, you say in the C, it would say, or in E. Sometimes people are doing wrong that after exposure suddenly go reassessment. But if you little bit discuss, for example, if you would say, based on my assessment on primary assessment, I found this patient has the upper GI bleeding, and it's due to what? Due to his alcoholic liver disease, or due to he is alcoholic or anything, etc. You have to, and so I want to prescribe this patient here 2 mg and the terlipressin antibiotic. Or you can say, based on my initial assessment, I found this patient has the sepsis. If I'm talking of sepsis station, sepsis so is likely due to his chest infection. So here I want to prescribe him the antibiotic. But keep in your mind, you already give the fluid. Of course, in C, you will know the patient blood pressure is low, so you already give the fluid there, right? And in the E, you will just verbalize to give antibiotics, pass a urethral catheter, or etc. And also, here you can add some another thing which is left behind. For example, you will say, and based on my assessment, I need to follow sepsis protocol. If you want to make it a little wider, I have to follow the sepsis protocol. We have given oxygen. So you know the sepsis 6 you need to follow. We have done the given fluid. We have done the blood culture and lactate level, and we had given the antibiotics. Now we are going to also pass the catheter. So this is sepsis 6 protocol, right? Similarly, you can do in upper GI bleeding. So if you give because in the C, you give the blood because you want to stabilize the volume, right? But antibiotics, you can skip there, and you can give in the end. It's up to you. So nurse will give the antibiotic in front of you. So it's all depends on you whether you want to give in C or you want to give in E. So I would say it would be grateful if you think you can manage. Would say, based on my assessment and primary assessment, I found this patient has upper GI bleeding due to this liver disease, blah, blah, blah. So I want to prescribe him 2 mg terlipressin and antibiotic 1 gram. Please, nurse, would be helpful if you could pass the catheter and also the NG tube. And apart from, meanwhile, I continue my assessment. Something like that, or would say, thank you, and let's reassess the patient now. The nurse will say, yeah, done. Maybe she will say, yes, done, doctor, done. So that means she gave. Because they will not, of course, it takes time to do in real time, but you have to verbalize. So what looks good to you guys? I want to know your opinion. What to say these things in C or to say in E?
In C.
In C.
Yeah, I also think so. It would be, it's because you need to stabilize the volume in step 2. Would be better, so you guys say C, right? Or say E?
No.
C.
No, C. So maybe in E, when we'll ask about the assessment, so we'll get the result of the intervention we did in C. Like if we give blood, for example.
I want to tell you sometimes I don't think so lactic results you can get in C. No. Likely you can get the lactic level result in E. Why I'm saying that? Because in C, just now you take the blood, you send the blood culture. But in E, when you say based on my assessment, the patient is likely sepsis, is due to how to say, due to the chest infection, but I still need to confirm with the lactate level. So could you please give me the lactate level? Maybe before you verbalize this thing, maybe the nurse will hand over you. It's up to you. But in anyway, it's no problem if you want to do it C or E. But I mean, when you are discussing the team, would it be better to go in E something to leave after? Because suddenly jump up to reassessment, it's still not very good. Because in C, you need to stabilize the cardiovascular system overall, not any other things. The other thing you can add in E. It's up to you. What looks better to you? Anyway, I still aid in C because I know that most of people are learning this way, so it will look maybe easier for you. But overall, I would say better to choose E. Okay, disability. Let's come up to disability. You would say, the nurse, could you please help me to check the sugar level because it's nurse job you can't do. And meanwhile, assess patient level of consciousness. So if the patient is conscious, you need to ask a few questions, as I said. Sorry, here is the place. Okay, time, place, and person oriented. So you need to ask this question. If patient is unconscious, when you check the GCS, the nurse will say the patient GCS is 13/15 or E, blah, blah, blah. She needs to verbalize too. And then you will go for the check the pupils by yourself. When you will check the pupils, the nurse will comment on you equally reactive. After that, you need to go for exposure. And the exposure would be here, the patient, please expose the patient completely. If he's talking, you need to take consent from him. If not talking, then you need to just go expose and check the abnormality, like pull the hand, arm above and check it if there are any rash around armpit or around any other area, any swelling, anything. Then you should ask the nurse, could you please help me to check the temperature? And nurse will tell you, temperature is this one. All right, so this is about the journal and simple, the simple station to carry. So now what happened? Once you give the O negative blood, you need to mention the time to please give the O negative blood. Now it depends on the nurse. If nurse say is given already, that means she wants to let you stay here. For example, do we have a negative blood? Please transfuse the O negative blood right now. Okay, it's done. Nurse say it's given. It's already given. Or if not given, then you say to nurse. I mean, if the nurse says it's not given, when you ask her is given or not, if she said no, that means she wants to let you move on. Then you need to continue assessment. If she said it's given, then you go for the primary pack. You need to go for secondary pack. It's up to you. Depends what they want to test you. Now, once you complete the primary assessments, yeah, you have to go for secondary assessment. So as I said, nurse, if you didn't give terliprase antibiotics you want to give, you need to here say, first say, after exposure, always verbalize. I didn't write it, but I want you should note this point. Always verbalize. Based on my assessments, based on my initial assessment, or based on my primary assessment, I found the patient has GI bleeding due to that. I found the patient likely have this problem. So I would ask, could you please give the antibiotic or any intervention you require here, you need to do. Let me reassess the patient. After that, when you reassess the patient, again, you go for airway, oxygen saturation, blood pressure. The nurse here will say, look at the monitor. So if the nurse first in primary assessment say to you to look at the monitor, then you need to always look at the monitor. So while reassess, okay, I see the monitor shows the patient oxygen saturated. This means the airway is patent, patient is doing well. Then you move to blood pressure. Oh, I see the patient blood pressure monitor is this one. Okay, it's still low. Could you please transfuse the primary peg to this patient? That include the full 4 RBC in 4 FFPs. Thank you. And also, please give me the VBG or the blood results as soon as possible. Thank you. The nurse here will say, given. Now, could you please give me the result if you have it? The nurse will show you the blood result and she will, I guess she will give you in your hand. Or she will verbalize the hemoglobin is that, FFP is that. blah, blah, and then you will, according to that blood result, you have to take the action for the secondary pack. Okay, secondary pack always depends on the lab result. Now, what happened to some candidates, including me? What happened when I went for the secondary pack? The nurse said to me, "Doctor, the patient is unconscious." First, she was talking, but here, when I reached it, she said unconscious. And I say, "Okay, is there a sign of life?" I have to, because I have to go for look, listen, feel. I pretend to do that. And she said, "No." And I asked her to store the high quality CPR. And I went for the Alice protocol. When I complete the hypoxia, it's all for and 4 days. And then I asked her, "Is 2 minutes past?" She said 2 minutes past. And what about now? Is there a sign of life? Yeah, there is sign of life. And I appreciate them. And now I ask them, is the ICU team here? And the gastroenterology, we have to hand over this patient. And I still have around a few seconds, I think. Then I verbalize, okay, about the post-risk management. This patient required intubation. Please keep on high flow oxygen. Patient currently on the backbone mask. The cardiac arrest is the same. You need to follow the protocol. Okay, it's the same. I mean, sometimes, as I said, I had a station says to me that the patient went to cardiac arrest, but it's not the case for everyone. It's possible maybe you will have a station is a cardiac arrest later when you are going for reassessment. So it's likely they want to test you in both places. That means resuscitation is complex. Okay, so you should be ready. So once the patient goes in a cardiac arrest in reassessment, then you need to follow their protocol. Alice. Okay. So this is massive transfusion protocol. If patient is bleeding, collapse, or clinical shock, then you need to go for the O negative blood after that. And if it's a trauma, you need to give the tranexamic acid, okay, for 10 minutes. But you can consider, as I said, in other part, you will send a cross-match cladding screen. So the primary pack is here, which includes 4 or 6 unit RBSA. And the secondary, before secondary pack, you need a result. If hemoglobin is 8, less than that, you need to store it, otherwise not. And platelets should be greater. If less than that, you have to store it, okay? So this is about the massive transfusion protocol. So primary pack, you don't require any blood, any blood test
Dr.
or any, yeah, excuse me?
There's no screen. I don't know if it's just me.
We are seeing the screen.
We can see the screen, maybe it's just you.
It's just me?
Yeah, maybe you. Yeah, because people can see the screen.
Okay.
Let me check it. What's the problem? Could be. What's your name, please?
Nelly.
I think
Nelly.
maybe you have problem in your site. So you just check out. You can join again. Okay, so the primary pack doesn't require any blood test result, but the secondary pack, yes, you have to go for secondary pack. But before going that, you need to confirm the blood result. Okay, hemoglobin and then you have to transfuse accordingly, not the way you do in primary pack. Okay, thank you. Let's come up to I'm going very slow, the resuscitation bradycardia. So the same, we have to go with that. Okay, the most important part is here. You must keep in mind, maybe you didn't notice, you must keep in your mind that you all should be in PPE, okay? You must wear the protective your equipment. Okay, so once you confirm patient is conscious, that usually patient in bradycardia can be unconscious, can be conscious. Both can be possible. So the airway is patent. No, there is. Sorry. This has been written about. No. Okay, so how's the airway patent? Please high flow oxygen. Okay. The similar way you have to go for a B. You need to go for respiratory rate high fluxion. Similarly, the important intervention would be here in circulation. So this is a little bit different. So the same, you need to check the vital parameter or either on the monitor, but you need to verbalize, could you please help me to check his blood pressure and heart rate? And meanwhile, I'm going for to check his pulse and CRT. Once you've done it, then you need to ask her to the same step. You need to take insert to lower bore cannula, U and E's. Always forget. I'm sorry. So, and cross match doesn't require in this patient, so we need to remove, and toxicology. As soon as possible, take an ECG. So ECG, you need to verbalize. Take an ECG, provide me with the strip as soon as possible. Nurse may indicate to watch the monitor or the verbalize, but you have to verbalize. Means then maybe she can give you the ECG strip, or maybe she can ask you to check on the monitor. Anyway, then you need to find verbalize the finding, like you need to according to the patient condition or the patient vitals or normal, not normal, blood pressure is blah blah, pulse is low, etc. While you're looking at the monitor, which indicate patient in bradycardia. So please call the cardiologist, if not yet, and give the 500 ml normal saline bolus in atropine, 500 microgram, repeat every 5 minutes if required, up to 3 mg. You need to verbalize that. Please apply pacing pads, and patient may require pacing later, and prepare sedation analgesic drug. That's very important, because if the patient is conscious, they need sedation, conscious sedation. But if patient is unconscious, then it doesn't require it. Okay, so that's why you have to verbalize that. And if it depends on what kind of patient you have, conscious or unconscious. So once you've done it, then you have to go for next. Meanwhile, we continue our assessment. Meanwhile, I continue my assessment. Again, blood glucose level, you need to ask nurse. And then, now please, don't need to think like GC should be first, blood glucose should be in the end, pupil reflex should be first, or in the end, or in the middle. Don't know. You need to take the steps accordingly, which make a concise way. Like, for example, blood glucose level is not your job, right? So you can say, nurse, could you please help me? Could you please check the blood sugar level of this patient? Meanwhile, I assess the patient level of consciousness. So when you assess the patient, if it's conscious, then the same 3 questions you need to ask him. If it's unconscious, then you need to pertain to check the GCS, and the nurse will help you to know what's the GCS of patient. Similarly, again, what about pupils? Check by yourself with the torch if you have it, the flashlight. Intervention is depends what is the patient GCS. Again, please expose the patient completely, check. And now let's come up to the important one, the reassessment part. So reassessment part is here. Well, you do reassessment. Before go reassessment, it would be better if you would say something about, based on my initial assessment, patient has bradycardia, patient ECG strip is this one, and the cardiac defibrillator paid attached and off if you want to add something like to give patient the pass the urethral catheter, you need to verbalize in the end. But if not, then if not, then you go for the reassessment. Again, airway, oxygen saturation, baby, again, you need to check the monitor. Patient will say, if it's the same, then you need to go for pacing. Now, the problem is that there are also the drugs, isoprenaline, we can also give, but the problem is that for that, we require CVP line. That's what we call the central venous. So, and that's why you don't need, and we don't have to test that one here, but I go for the pacing. The most defibrillator pads have the pacing. So what you'll ask your nurse, please change the defibrillator to pacer mode. Okay. And pacer now. When start the pacing now, start a 70 rate, okay, 40 milliampere current. But if you you should look at the monitor. I mean, on the defibrillator to check on the screen that either this is getting the electrical capture or not. If you found there is no electrical capture, then you ask your nurse, could you please increase the current further to 60? If still no electrical capture or intermittent, then you again ask 80, even go 100, you can go 120, even go 140 until you got the electrical capture. Once you got the electrical capture, now then you need to verbalize. Okay, I see, excellent. We have got the electrical capture. Now I need to confirm with the mechanical capture to check the patient blood pressure. And then you need to look at the monitor. If blood pressure is improving, then the patient is going well. Okay, so this way you need to verbalize. And in the end, you need to appreciate your team. Excellent, guys. We have done a great job, and we see the patient is doing well. And then after that, you need to ask the nurse, now we want to hand over the patient to ICU team or cardiologist. You need to verbalize. Then you have to go for that. If it's not, then you go for next approach. But if they want, sometime examiner do make the station complex, again, they will make the patient cardiac arrest. And you need to take the step following like steroid, CPR. I think it's very simple and very straightforward. Even you can just, whenever, in case this station comes, you can verbalize the same thing. How's this sound? Is there anything missing? You can edit by yourself, no problem. There is no any restriction. But I want to stress out one thing, that don't need to ask the nurse everything. If you can do something by yourself and visible on the monitor. Okay, your intervention or should be concise and specific to the area. Like something you can do in C, then you should do in C. If you can't do in C, then you can do in E. As I said, again, I want to stress out, in the C, you need to, your most focus should be cardiovascular system stabilization. In C is not you don't have to focus on need to give antibiotics here, we need to give these everything here. No, you can do these things in E, which is relevant, because C is relevant to circulations. The circulation should be stabilized in C. But other things like catheterization or these old things you can do in E. Okay? I think it's clear to everyone.
Yeah, we will do the pacing in treatment, or we will do it in the closure.
Couldn't get you. What did you say?
Sir, in your scenario, you have given all the details of pacing, the capture and the current in the closure and the reassessment. Will we be doing it in reassessment or during circulation review?
No, that's a very good question. This in a reassessment, when you do, like for example, now look, this is where you will know the heart rate and blood pressure, in which place?
In circulation.
Yeah, then you have to go. This should be done in circulation. Okay, pacing should be done in there because you need to do there, and the paid should be applied in the primary assessment, right? In the secondary assessment, you need to, if it's still the problem is ongoing, then you need to ask the nurse to change the defibrillator paid in the pacer mode and install it with the 70 rate and 40 milliampere current. And if you found that there is no electrical capture, then you go for you need to ask a nurse, could you please increase the rate of the current, or you do by yourself if it's very close to you, if the nurse asks you to do. Now, that was your question, right?
Yes, sir. Thank you.
Okay.
Yeah, hi.
Okay, so
what time added the adrenaline or isoflurane?
Yeah, as I say, it's for adrenaline and isoprylane, they need to be stored in infusion, right? So the problem is that they need to be stored in infusion, so and they require CVP line. So I would say better to skip them. But if you want to verbalize it, we will come up to second line drug or second line intervention. So it's okay, but I don't think so. For the exam purpose, they want to test you in bradycardia, second line drug. They want to actually test you in bradycardia, this pacing. Okay.
Okay.
Okay, so now you could see that I want to show you in pacing. So not very good at drawing, but I could try to help you. Now look at this one. This is the. 1 second. Need to change the color. Now you could see here is the beat. We are giving this pacing beat, but you could see that there is no QRS complex has been followed here. But that means it's not in. We need to still increase the current. But here you can see that it's always like that white QRS complex after every pacing beat. So you can see that here is. This is when we reach the current to 140, and this rate is the same still here. So the current we has increased when we reach to 140, then you can see that in every after beat we find the QRS complex wider. So that means this is the electrical capture, but that's not enough. Then you have to confirm with the blood pressure. You need to check the patient blood pressure. If patient blood pressure is improved, heart rate improved, that means it's work fine. That's what we call it mechanical capture. Or electrical capture always be confirmed with the mechanical capture. Clear so far?
Yes.
Yes, sir.
So what the examiner want to test you in bradycardia, they want to test you pacing. How you go for pacing in the patient with the bradycardia. So you need to remember the 70 current, the rate and the current should be start with 40, 60 is up to you, and every electrical capture should be confirmed with the mechanical capture. Okay, so this is the algorithm we have it. Oh my God, I don't know
You
how
have to mention, Dr. B, this is unstable bradycardia or with low blood pressure, then I will go for atropine.
Excuse me, what do you say? Could you please repeat? Pardon?
Yeah, I told you regarding the bradycardia, I have to mention this is unstable bradycardia or bradycardia, and I have low blood pressure. So I want to give the patient atropine 5 microgram like that.
Now you say the bradycardia is always, if they want to start a resuscitation, the patient should be unstable, not stable. Okay, always be unstable. So because if they don't make the unstable, so what might be they want to test you? They actually test you these things, so they will make it always this thing unstable. Like maybe the scenario will come, the patient has a syncope or shock, etc. Like that. This kind of scenario you will get it. So overall, I would say so the bradycardia is always like that. So you don't have to worry about that. Now let's come up to the next. It's clear so far about the bradycardia, right?
Yes.
Okay, now let's come up to the tachycardia. So tachycardia is a similar way. Almost everything is same. The few things we have to different is in C. Okay, so now look at here. When you check the rhythm, when to large verbalize the finding, look at monitor, comments. Okay, so now look at the monitor, or if the patient already, for example, is unstable, you had to monitor everything, then you have to check it out. Is a patient blood pressure is low, then you have to go normal saline, etc. Or if it's required, the defibrillator. Again, one more thing I want to highlight here. When you're going to, so which tachycardia need a defibrillator, guys? Could you please tell me a little bit about that?
If unstable, it will be shock operative.
Yeah. What do you mean by unstable?
Unstable that if we found the patient hypotensive, or there is chest pain, or there is heart failure.
Yeah, that's very. The adverse features we have to know about all the adverse features, which are very important here. We can check it out here if there is. Yeah, shock, syncope, myocardial ischemia. Myocardial ischemia maybe not come like the way you think. Maybe the chest pain. If the scenario show you the chest pain, that means if in the monitor show you tachycardia, then you have to go for the intervention, for example, like defibrillator. Ask the nurse, please, that is a defibrillator paid. Okay, and if patient is conscious, then you also need to give the conscious sedation. Okay, and then you have to go first shock, second shock, and third shock, etc. Okay, so it's a similar way, but a little bit different. If they found the blood pressure is low, you also need to give the normal saline and they give conscious sedation. This I want to stress out. Okay. If the patient doesn't have the adverse feature, then you have to start with the amiodarone, or if it's ineffective. Okay. I think you're very familiar with that. Or I need to stress out something here.
Yeah, no need.
Oh, right. Yeah. Okay, so the treatment is Bragg complex. If it's a narrow complex, you always need to think about SVT. If it's Bragg complex and regular, always think about VTAC. Likely, but it can be different, but likely be the VTAC. If the patient is stable, okay, if the cardiac monitor show you narrow complex and you found it's SVT and patient is stable, no adverse feature, then you have to go for adenosine. Adenosine, you have to store 6 mg and in 12 and 18 mg according to Resus. Okay. And other than that, you also need to ask that please attach the defibrillator page. Maybe patient need a second line treatment. The first line you will give the vagal maneuver. In second line you will give the adenosine. If it's not effective, the first one, then it's still not effective, then you can think about synchronized DC shock. Okay, so next station we are going to have very, very important, very, very common station is called anaphylaxis. Now, the anaphylaxis, the scenario will show you maybe patient has a rash, but they will not mention you the patient is systemic compromise. Okay, so last two stations which I have got it from my colleagues and my friends, they said in the exam the station come with anaphylaxis. The patient has taken medication and he has a rash all around the body, and now when the patient just has a rash, but they didn't mention the systemic compromise. So in this case, the station goes in two ways. So the rash can be urticaria, can be another reason, or it can be anaphylaxis. So you know that anaphylaxis criteria is systemic compromise with or without rash. This is the anaphylaxis, the criteria. But if patient just have a rash, it doesn't mean that the patient has anaphylaxis. So what happened? Now you have two things to do. If you have this kind of scenario, patient systemic not compromised, I mean he's okay, and during just rash mentioned, you verbalize everything to the nurse. Okay, I mean you introduce yourself, you got the introduction, everything you've done, and you got the oxygen, everything, this all equipment done. And now the one thing is I want to say that maybe you need to ask also the nurse to prepare for CVP line, because if patient goes in refractory anaphylaxis, then you have to start the infusion with CVP line. That's very important. So maybe you can ask her to prepare. Anyway, so again, the same way. Now, very important thing is in airway. Now, in anaphylaxis, if patient is talking, patient is talking, that means the airway is patent, okay? But if patient is not talking, maybe she will say, this is very, very common. The patient there is hoarseness or a stridor. Now what you have to do, you'll ask to apply half-oxygen is required when non-rebreather mask. But the problem is that about the adrenaline. Now you will think whether to give the adrenaline here or not. What do you think, guys? Patient has rash and you found the patient has hoarseness, stridor, but this rash you found on outside in the scenario, but still now you didn't see the rash, but you found the patient has stridor and hoarseness. What would be your state? Will you give adrenaline? Will you give adrenaline? Will you give adrenaline or not?
I will give adrenaline after airway session.
Yeah, we have to give.
Okay.
We have to give and oral anesthesia also.
There should be two systems to label the anaphylaxis. So there is only one system here now in this scenario.
Okay.
From scenario, we can suspect it is the anaphylaxis already. From scenario, you can suspect it.
This is what I think. Now, what's the problem? The mostly people think now you have two choices. Now look. Now, as I remember, once happened to one of my colleagues like that. He said the anaphylaxis, there was rash mentioned. When he come up to inside the station, the nurse said, doctor, there's a patient, he has a rash all around his body. Now look, the nurse is giving a briefing about the patient. In that case, if you got the briefing like that and you found the patient is the airway compromised, then you give adrenaline here, okay? Another thing is that if you haven't got the briefing, but you know outside is written only, but you didn't see by yourself because you even didn't reach that place, right? So better to, when you do an inspection of the chest, you found the rash. Patient had drug, he has taken drug, and the systemic compromise like difficulty in the airway, give the adrenaline in this place in B. But if you already got the breathing, everything, and you found the patient airway compromised, then you give an A. Did you get my point? No problem. You give an A or in a B, no problem. Both are relevant. I mean, both are relevant to each other. So it's no problem. And now regarding your call to anesthetic, it can be better. It would be better you say in B, not in A. Why I say? Because in A, you just now give the adrenaline, right? So patient can be improved. Maybe no stridor, hoarseness, right? So
according to the problem, if in the airway, I will give him the airway. If in the breathing, I will give him the breathing. If circulation, I give him circulation. I think like that, doctor.
You're right. You are right. But I mean, if you got the briefing about the patient, if patient, you know the drug taken, yeah, that's cool. But systemic should be compromised either the airway or the breathing. But I would say if you give in breathing would be better because in inspection you will also see the rash, and that's really, really confirmed that the systemic compromise with the rash. Anyway, one single the criteria is enough for anaphylaxis. Single criteria. I mean, if the hoarseness voice is right, you can give no problem. But I mean, if you give in B, is also that would be much. I think it's a lot better than TA. Here you can also see the rash, everything. Okay. Now it's up to you, but yeah, it's up to you. This case would be like that. The patient might has taken drugs, and since then, after that, he developed the rash all over body. But you don't know this is urticaria or it's anaphylaxis. But when you come in the station, when you go airway, you found the difficulty breathing. So that could be confirmed that it's anaphylaxis. But if more appropriate, it would be if when you chest inspection, you find the patient rash. So you saw by your eyes. That's clear everything. So it's up to you if you give an A or B, but no problem. It's you can check it by yourself. If the nurse give you a briefing and then starting, then you can give an A, is no problem. Okay, so once you give the adrenaline, then you ask a nurse to repeat the dose in after 5 minutes, and you will ask a nurse to prepare the infusion. Prepare what? Infusion. Infusion. What is the criteria for infusion, guys?
Refractory anaphylaxis.
Refractory anaphylaxis.
After secondary assessment.
Yeah, not after secondary, after 2 doses of adrenaline.
Second dose.
After 2 dose, after second dose, yes.
Yes, after second dose. So this is what I want to ask you. So how you will give infusion? 1 mg per ml in 100 ml normal saline.
100.
1 into 1 into 1000. Okay. Just remember, when you verbalize that, you need to say that. So if you give adrenaline here, then you need to ask her prepare for the second dose and repeat or need to repeat in second dose. When you come up to the second dose, for example, now in a B, you come up post oximeter, you use it, saturations improve or not improve. Here, if you found that the respiratory rate is increasing but saturation is low, or the respiratory rate is low, then you have 2 choices. You have to either connect to the back wall mask and also ask the nurse, please call the anesthetic. Anesthetic should be called here because maybe after first dose, patients improve. Can be improved, right? So after first dose, if you found the patient conditions improve, that means it doesn't require anesthetic. But if you found in breathing after first dose and you still found the patient is not improving, that means you really, really need anesthetic, or you have to change the, you have to do intubation, or you have to apply the supraglottic airway or any, etc., or back wall mask. Okay? So I would say the anesthetic should be called in B, but it's up to you if you want to call in, it's more feasible in B. Okay, so now the next step would be to expose the chest, and the inspection you need to verbalize as I'm finding the racial or his chest. Palpation, you need to put your finger to check the trachea. Anaphylaxis, the station, still now what I know, always you need to do by yourself, means you need to take the step. You have to do palpation, percussion, auscultation. So the palpation, you also do the same way, check for the trachea, check for the chest expansion, then go percussion, then go auscultation. If you find the wheezing here, it's no problem. If it's still wheezing, maybe you can try second dose, but may not. You can ignore, no problem. Wheezing is not specific to that. But in circulation, if you found the patient is still in there, then you go for a second dose. Okay? It's not necessarily you say in wheezing you find and you need to give the second dose. No. You just now give the dose and you're still in breathing. Once you cover the breathing and you go for circulation, in circulation you found the patient is compromised with the blood pressure, etc. Here you can go for second dose. And after second dose, you need to verbalize it. Please prepare the infusion. Patient require may goes to secondary patient in or may. If already done no improvement, then he is in refractory. But if it's you just now going to give, then you say patient might go to refractory anaphylaxis. Please prepare the adrenal infusion for the patient and call the anesthetic if not arrived yet. Okay, good. After doing that, here also you need to give the bolus and also ask the ECG. You need to verbalize what is written here. But one thing is important. When you give the adrenaline, make sure to give adrenaline where. And so you have to verbalize, please give the adrenaline IM in the anterior lateral to middle thigh. Okay, and asking nurse, please prepare second dose. Patient will need second dose in opposite thigh or in the right or left, whatever you're going to, but the opposite one, they're not the same. Okay. So here is a blood pressure low, pulses rises, come in accordingly. Please call the ICU team. Okay. If not, then if not yet, give the 500 normal. If not yet, because you have to call earlier, but if not, so that's why it's mentioned. So again, you need to remind them and give the 500 ml normal bolus for blood pressure and second dose of adrenaline. A patient is compromised with the blood pressure. Meanwhile, you have to continue assessment. If the patient if the nurse says it's given, then what you have to do?
Prepare for infusion.
Yeah, need to start. No. Then what you have to do, then you have to say, please continue. I am talking about C, not reassessment. I'm talking about C. If nurse said is given, then second dose also given. Now, if patient is in refractory, so what you will say? You will say, please continue to give the further dose of the adrenaline IM every 5 minutes until adrenaline IV infusion is ready. Did you get my points?
Yes.
Okay.
Yeah, because it's not ready. You're going to come in to prepare now after second dose, but it's not. But she said it's given, and it's not ready, so she needs to continue to give every 5 minutes until adrenaline infusion is ready. Okay, and then confirm it's ready. Then you need to store the adrenaline infusion, and meanwhile you continue assessment. So again, the same disability.
Doctor, any problem if give adrenaline in the second assessment?
No. Okay, there is no any problem. I say to you, there is no any problem. But if you ask the nurse to give the second dose of adrenaline and she said, I give it, now what to do? Now that means she wants to see that what is your command now. Your command would be like that. Oh, it's given. So what about the blood pressure? You will check on the monitor. Okay, you reassess, means check the blood pressure. You see the patient is still systemic compromise. Then you will command that, okay, the patient is in, patient now is in refractory anaphylaxis. Could you please continue to give the adrenaline further every 5 minutes till the adrenaline infusion ready, please, or you can say prepare for adrenaline infusion ready. And meanwhile, continue to give the adrenaline every 5 minutes IM. Like this, you need to command. So they want to test you from, it depends how they want to test you. They want to test you everything here in C, or either they want to test you, maybe they want to test you everything in C, and then later they will give you in reassessment patient in cardiac arrest, as to make it station complex. Similarly, I said about for GI bleach, they want to test you to give the O negative blood, but maybe they will ask you is given. So then you will ask her, could you please check blood pressure now? What is the blood pressure? It's still the same. I see on the monitor. Okay, it's the same. Give the primary pack, maybe. And she said, okay, then the blood result. Okay, so could you please tell me blood result? It's not. Say, okay, you have to wait for the blood result. Meanwhile, I continue my assessment. You can do that. So it depends. So when you do reassessment, maybe they will make it for you cardiac arrest. Or maybe your primary pack you give in a primary assessment, in secondary assessment, you give secondary pack, and then cardiac arrest. It depends how they want to run this, to make the station for you. But anyway, you have to ready for every scenario. So again, if the nurse side is given, then you have to check the monitor. If the blood pressure, everything is still low, that means you need to verbalize. Say, okay, I see the blood pressure is low. That means the patient is in refractory anaphylaxis reaction. Could you please prepare the IV? Could you please store the adrenaline infusion? Maybe the nurse say it's not ready, or it's not prepared. Okay, could you please prepare it? And meanwhile, give the adrenaline every 5 minutes. So this is the guidelines which we have in the Resus Council. So this way you can change the way of your, to communication, and you have to take a step accordingly. Clear so far?
Yes, sir.
Yes,
no, I don't mean that you must give everything in a B, in C. I mean, it's possible anything can possible. So you need to know what to say if already 2 doses go. And maybe you think, oh, I need to reassess. Then no. If you give the 2 doses already, then you ask the nurse to stop the adrenal infusion. If not ready, then you ask her, please give the adrenal every 5 minutes and prepare for the adrenal infusion till that. So this is what you can say. And meanwhile, I continue my assessment. You will go for a day. You say, please, nurse, could you please help me with the blood sugar level to check the patient blood sugar level? Meanwhile, I assess the patient level of consciousness. Patient is unconscious. Then while you're doing so, the nurse will comment. Yeah, patient is, the GCS is available. Or maybe if it's conscious, then again, you have to go for time, place, and the person. Last one is pupil reflexes. What about pupils? Check by yourself. Intervention required as per the GCSM if you found. Okay, please expose the chest completely. Here you will check all the ratios, even raise the arm of the patient, leg to check everything. And you also ask the nurse, could you please help me to check the patient temperature? And the nurse will give you an answer. Yeah, it is like that. And then when you are going for reassessment, before reassessment, again, I want to stress out, you need to discuss a little bit to verbalize something like, okay, based on my primary, so it would be better you always verbalize your primary assessment. Based on my primary assessment, I found this patient is in refractory anaphylaxis or patient in anaphylaxis. I give him 2 doses and might be student secondary. Please make sure that a patient fluid is given. Or one more thing, is the trip test level test is ready or not? You can ask an E if you want. Okay. Well, let's go for the reassessment. You will say, and reassess the same way you do. Maybe the patient go cardiac arrest, maybe not. Or maybe you can hear a taste adrenal infusion. And in one more thing. Now, when you reassess the patient, if you found the patient airway is still compromised, there is dry hoarseness. So what you will say, ask the nurse to store the nebulize with adrenaline, okay? And also taste the adrenaline infusion to the patient. You can say in A, you need to take the intervention here. And then you go for the oxygen saturation, then you go for B, and so I'm sure that they will make it stabilize patient here, or they will make patient cardiac arrest. If they say there is no sign of life, then you have to store the ALS protocol. I think it's simple, or it's complex.
Yeah, that's good, doctor. Thank you.
Yeah, very nice.
Simple.
I think everything is written here. Just what you have to do. Go and just verbalize what is written. You're done. No worries. Okay, so, but remember one thing, the communication, because I didn't write how you communicate. Like, could you please help me to check the temperature? Remember, you guys are doing big mistake when you're asking what is the temperature, what is the blood pressure. But even though these things in front of you called a cardiac monitor, so why do you ask? You need to verbalize, could you help me to check the blood pressure? The nurse will say, yeah, there's a monitor here. Or once she showed you the monitor, then you all think you need to check over there. And this will help you to save time as well. And then you comment accordingly and check the intervention. That's it. Okay, so this is the algorithm of the anaphylaxis. I think everyone knows about it. It's not very difficult. Let's come up to the station is drug overdose. If I tell you a little story about this one, this station, I especially written it and I made it for you. What happened, one guy, he was I think maybe he has 3 years experience, even 4 in ICU. And he gave MRCEM in London. And the problem, I don't think so, it was his problem. The problem, he wasn't aware of such kind of stations that he might have it. Now you also know still now what the station we had it, they all are present is a resuscitation and they are not initially in cardiac arrest, right? And this station going to be initially in cardiac arrest. So this is your station would be also first. So similarly, this guy, mostly, you know, they practice like ABCDE protocol. So they think this is also the ALS. That's a resuscitation, but ALS approach a little bit different. So what happened when he go inside in the station? He followed everything, but the problem was that he didn't know what is the cause of this patient. And you know what happened? The nurse not bring nothing for him. He's stuck there a long time. He doesn't know what to do. For example, he said, start CPR, high quality, then he gives shock, second shock, third shock, give adrenaline, give amiodarone, everything, but patient is not going to be stabilized. He's really confused. That's what's going on. The problem was that he didn't go with 4H and 4Ts to focus on the reversible causes. And he lost his station. I'm sure he got maybe 1 or 2. The reason is that in these stations want to test your 4H and 4Ts. Okay? Rest station we already saw they have to do the initial approach, and then the patient go cardiac arrest, and we did follow the ALS protocol, so everyone knows about it. But this station is very complex, and this is what happened to him. And he was very disappointed. The reason was only one thing, 4H and 4Ts. If he just once verbalized, I want to go 4H and 4Ts, and when he goes with the hypoxia, I'm sure the nurse should give him in the box of the medicine and show him that the patient has took this medication since then he's like that. And that help him to stop the reversible causes and continue assessment. And patient finally stabilize and hand over to specialty. This is how some session could be run. So you should be ready for that. Anyway, the same way we have to introduce yourself, everything, check competence, everything, call the cardiologist or anything you think what could be the relevant to, better to call the ICU team, because if you are not sure, okay. But if once make sure is the drug cause is due to drug, is CCB, calcium channel block, then you can ask the nurse to call the cardiologist. Okay, the similar way, the problem would be here you will have the, here is a patient here, okay, patient conscious, unconscious. Please check sign of life you have to do by yourself. Means to act like that. No, that means patient is cardiac arrest. Call the ICU team and anesthetic installed high quality CPR. And now, what you have to do, you said this story. You say, please store the high quality CPR 30 to 30 compression 2 vein and attach the back wall mask. And also, please expose the chest of the patient connected to the cardiac monitor and attach the defibrillator pad. Please nurse be enter the 2 large blood canal extra the blood for full blood count, VBG electrolytes, and toxicology screen. Chest rhythm, check the rhythm on the monitor. When she attaches it, you have to check, I see if it's shockable, it's VFib or the pulsar VTAC. Then please give the first shock. I clear, you clear, everyone is clear now. Deliver the first shock. You need to verbalize. Everyone is clear. Okay, remove this following equipment if you want to ask the oxygen mask, etc. And give the first shock 150 joule and immediately resume the CPR for 2 minutes. Now, once you say the immediately after first shock, you say the immediately resume the CPR for 2 minutes. Then you say, I go for 4H and 4Ts. And then you will here go for hypoxia. Okay, the hypoxia, either you verbalize, okay, guys, we say the hypoxia we are managing here with high flow oxygen and CPR. So it's less likely here. Hypovolemia is likely can be, but there is no bleeding or trauma. Hypothermia, could you nurse please help me to check the temperature of this patient? Yes, doctor. And she will check the temperature and she will tell you, yeah, that could be normal. That's not possible in this patient. That's likely. Then you hypoglycemia and hyperkalemia. So we are waiting for the blood results. Or do we have the VBG? If the VBG have, so you say what is the potassium the level? You can check it. Likely they will have the VBG there. And also, could you nurse please help me to check the check the blood sugar level of this patient. Like what I'm saying, you need to verbalize, guys, okay? As a nurse to do. Okay, so blood sugar level is normal, potassium level is normal, that's mean no any problem in hyper and hyperkalemia is okay. So tension pneumothorax, then you have to auscultate the chest and say, okay, I see that there is equal internal on both sides, so that there is no chest pneumothorax, tension pneumothorax. Tamponade, a nurse, please, echocardiogram should be done. Check it, maybe is there is any cardiac tamponade. Thrombosis, in this case, less likely. Is there is no any there is no any history of acute MI or anything. You can rule out, and the toxin here is likely because the patient has taken an overdose of the calcium channel blocker. Okay, please store the calcium chloride antidote for this patient, or if they require antidotes, you need to ask her, and then or you ask the calcium chloride, calcium gluconate according to the requirement, like 10 ml, 10% 10 ml of the calcium chloride. Okay, so once you say these things, then you say, has 2 minutes passed? Remember that when you ask her to resume the CPR immediately after the first shock, then when you will ask the nurse, has 2 minutes passed, I'm sure the nurse will say no. That means she wants to stress you out on 4H and 4Ts. Okay, so here you will treat the reversible cause such as calcium channel blocker. Then you have to store the calcium chloride, calcium gluconate. Okay, or inshallah with glucose. It depends on severe case. Okay, clear so far, guys?
Yes, sir.
Yes.
Please note that I am talking about patient in cardiac arrest. In case of not in cardiac arrest, then you have to go for ABCD protocol, and then you will see maybe patient in bradycardia and cardiac monitor. That's another. But this station is very common in the United Kingdom. It's 3 times almost came up. So it's likely. So, and I'm sure many of guys doesn't know how to go with 4H and 4Ts because many of candidates just know, okay, I will go for 4H and 4Ts. Yeah, it's likely cause a toxin. Okay, please give the calcium chloride. No. They want to check you how you rule out each and everything. Rule out hypoxia, hypovolemia, hypothermia, hypokalemia. Okay, then you can ask the nurse, has 2 minutes passed? If yes, please check the assisted rhythm and monitor a defibrillator. If it's still same, give second shock. Then again, resume the CPR. Meanwhile, I check another thing. I can see there is no change. Then you get third shock, then you give adrenaline or amiodarone, anything. Once you stabilize the patient, then you have to reassess airway, breathing, circulation, then hand over to specialist. Any question here, guys?
If the patient is not cardiac arrest, can I ask in between any history or any?
Patient is not cardiac arrest.
This is like
patient is not in cardiac arrest. That means you are going like a bradycardia.
Yeah, just in bradycardia.
You will go just like that. I mean, just like a bradycardia, but if the nurse say the patient has taken this medication, then you need to treat that according to antidotes, right? If TCA, you need to give the bicarb. If the calcium calcium channel blocker overdose, then you have to give the patient the calcium chloride gluconate or insulin with glucose. I think without cardiac arrest is the same as like tachycardia is like the same like bradycardia. Just a very important thing is the antidote. Okay.
If the cause of beta blocker overdose in bradycardia.
Yeah, if the overdose causes a beta blocker, they still need to go for because the patient is in. Of course, a patient should have the adverse feature. So you need to give atropine, but it's no effective. So then you have to verbalize the atropine is not affecting the patient. The patient is in a beta blocker overdose. So that means we have to give him the glucagon. You need to verbalize, or you need to start adrenaline infusion.
Yeah, that is my question here. If I have not any clue to To know this one, it is drug overdose, for example, beta blocker. So can I ask in history?
Yeah. It's not possible that you don't know the dose. I tell you right now.
Mm-hmm.
Look, when you come up to 4H and 4T, you saw this nurse came to show you the medicine. The same way when you will come to the C, okay, you found the bradycardia, maybe the nurse will come up to you, doctor, I found this medication. Then you have to treat according to it. Clear?
Yeah.
Clear.
She mean before cardiac arrest. She mean in case of not cardiac arrest.
Yeah, I'm talking about the cardiac arrest, not cardiac arrest. I mean, I'm talking about the same way I said. Look, when you come up to the circulation, you check the blood pressure, you check the heart rate, CRT, everything, pulse, peripheral. The nurse in that time will come up to you, give you a medication. The doctor, I found this medication with this patient. Then you have to go for antidote and also fluids if required. Take the relevant intervention according to the cause. Did you get my point? If you don't treat that cause and just go over without treating, then patient will obviously will go in a cardiac arrest later on, right?
Yes, clear, sir.
I think you guys, or maybe two things mixing. Here I am talking about cardiac arrest, so that's why I say 4H and 4T, but there are no 4H and 4Ts in non-cardiac arrest patient, okay? There is circulation. You will go for ABCDE approach, but in cardiac arrest patient, you don't have to go ABCDE initially, but in reassessment, you have to go, but here you will go for 4H and 4T. Did you get my point?
Yes.
I think it's very clear. This situation is very common. The cardiac arrest with calcium channel block are very, very common. You should be ready for that. Here, they want to test you how you rule out the other causes, how you going to treat the reversible cause. Okay? So you should rule out the way I said just now. Okay? I don't think so you have any question. Do you have any question here? Okay, so this is the CCB overdose treatment, calcium chloride, calcium gluconate, atropine sulfate, you see? Still we give the atropine sulfate here too. So the atropine sulfate always we have to give, but we must give the antidotes. In other TCA toxicity, we have sodium bicarb. So this is the antidote. Okay, so resistant sepsis is very favorite. I also guess it's the favorite for the RCAM. Okay, so sepsis. So what do you think the sepsis patient usually come up with how do you think how it's come to you? Is conscious or unconscious sepsis patient?
Conscious.
In usual in your emergency department, I'm talking.
Confused. Conscious patient.
Confused.
Yes.
Most of the time.
Confused.
Yeah. The resus is usually the patient come up like, I would say, confused, but not unconscious, mostly confused and conscious, right? That means they are conscious, but they are confused. Maybe they are not time to place orientate, but they are still conscious. Anyway, the same Dr. B introduction. And now what's happened is here. Now you have to see, is the patient here? Patient arrive here. Is the patient alert? Yes, sir. So what you have to start, the sepsis station, you have to start with your own way. The same as I said, if first initially it would be better, all stations should be started like that. Hello, sir. Hello, sir. My name is Dr. Bay. I'm the ED registrar. I am the emergency doctor today. May I confirm your name and age, please? But if the patient is sepsis and confused, he will answer to you. Maybe not right away, not very clear, but still answer to you. And you need to take a concern. I need to do an assessment to check you from top to toe that everything is okay. It will involve me to have a look, listen, feel your chest, and we'll also do some other tests. How I explain to you is I will go along. So you need to say to the patient, okay, whatever the patient is confused or patient would be confused, not in unconscious, okay? If they're confused, you still need to take consent because patient is not unconscious. Airway, you need to, that means the patient is talking, whatever is not trying to place oriented, but is still talking. That means a patient is airway is patent, and you need to say, I'm happy with the airway is okay. Let's move to the breathing. Yeah, you will go for the, please connect the monitor, pulse oximeter, or you would ask the nurse, could you please help me to connect the monitor or connect the pulse oximeter to check saturation and the oxygen and respiratory rate. Meanwhile, I will go for the lungs field to hear the lung sounds. You would say like that. So you will go for, again, you need to take the consent, the orbit consent. I need to examine the name of the patient, whatever the name. Okay. So I need to examine Angie. I need to examine your chest. Is that okay? Remove your T-shirt or shirt, please. He will say, okay. After removal, so this is inspection you have done, whatever. And you say, oh, now I'm going to feel. You just verbalize. Now you don't need to say him, but you just verbalize. Now I'm going to feel your windpipe. Let me know if you feel uncomfortable. Then check the position. I mean, then I pop up my hand around. Then you have to pop up your hand around the chest to check the chest expansion. You need to verbalize. Now, just gonna top your chest, okay, to check the sounds. Okay, hyperresonant, or you have to check auscultation. Now I'm going to quick listen. Now, remember that this is mannequin. The patient not going to talk, but you have to say because patient is confused, not unconscious. So now I'm going to quick listen your chest. The nurse will say, yeah, there are the basal crepitation or the crackles on the left. Okay. Now you found the patient has the crackles. You found the patient is confused about the patient. If you found high respiratory rate, a low oxygen saturation, then you will ask, nurse, could you please store the patient? I see the patient is low oxygen saturation and high respiratory rate. Could you please store on this patient on 15 liters of oxygen via non-rebreathing mask? Is possible? If possible, same ABJ. Okay, ABJ you have to do here. And request the chest X-ray, please. Okay, you need to come in as it may. So the nurse will say, yeah, I have the ABG here. Here's the ABG. And then you will say it's a type failure. Okay, so you need to keep on him oxygen. Then you need to find his acidotic or alkalosis. Yeah, I see the patient is acidotic. Okay, it's maybe likely the lactic, and we'll see. And the chest X-ray, if you have, oh, I see, this is look hazy on the right or left base of the lungs. This could be pneumonia. You just simple comment. Then you move to the circulation. And okay, so now I'm going to either you check on the monitor. Okay, I see the nurse. Could you please help me with the blood pressure and heart rate? Meanwhile, I check the peripheral pulse and also CRT, and you do it. Okay, and then go for cardiac auscultation. As I said, you could do in B or in C, up to you. But if you do in C in circulation, in sepsis, would be better. So I want to listen the heart. Now I want to listen your heart sound. The patient is conscious. You need to verbalize. Odema, now I have to look at your legs. Do you have any pain at all? Nurse, maybe will answer no, or maybe no answer because mannequin. Intervention, please insert 2 lower bladder canal extract the blood for the full blood count, EVG, UNEs, CRP, LFT, blood culture, and lactate level. As soon as possible, please take the ESRJ. So once you say here, and you saw on the base on maybe ECG you will get on the same time. Maybe the nurse will say, look at the monitor. If you found the patient has sinus tachycardia, and you have to come in, okay, I see the patient has sinus tachycardia and blood pressure low. Could you please store the patient with the 500 normal saline bolus, and please must check the blood pressure after fluid going through. Thank you. And meanwhile, I continue my assessment. So now you say the lactate level you just sent, and you didn't ask here. You didn't ask us, but you can ask in the E. Okay, we will come up to that one. If you follow this approach, this is excellent. If you follow this approach, I would say this is excellent. But if you don't follow approach, you want to check the lactate level, and I don't think so. You will get it. But if you really want to do it, so it's up to you. As I said earlier, in circulation, you need to manage volume. Cardiovascular system should be managed. Rest of thing, antibiotic, these several things you can store and eat. When you say you verbalize based on my primary assessment, I found this patient has blah, 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 and I want to store it. Please store or commence the antibiotic for this patient, and etc. You have to say. Okay, this epilepsy, I'm going to do neurological assessment. So could you please store the check blood sugar of this patient? You need to verbalize this. This you can verbalize in every stage. No problem in sepsis or in. Then assess the level of consciousness. If confused, now here you are going to check the level of consciousness, how confused he is. Okay, so now you will ask a question, time, place, person. What's the day today? If he's confused, he will not tell you right. Where are we now? Maybe he will give you answer incorrect. Who am I? Maybe he will say correct or maybe incorrect. It's up to you. Blood glucose level, nurse will tell you. Pupil reflexes, you have to check. Temperature, could you please help me, nurse, to check the temperature? Okay, so I'm going to examine further. While I'm going to examine further, now expose the patient now, or you can take the consent from the patient. Now expose. No, now I'm going to start to look for rash. I'm sorry here. Now, okay. On exposure, I haven't found any other. So now after this temperature exposure, you didn't find any rash, then you have to come up to your important points. What we say, you need to say, based on my assessment, based on my initial assessment, based on my primary assessment, if the patient is likely sepsis due to his infection in the chest. So we have to follow the sepsis 6 sepsis protocol, because you have to verbalize this, then you will get the score. If you don't verbalize the 6 sepsis protocol, you will not get the score. Oxygen, the patient on high flow oxygen. Okay, then you have to say about the fluids we have given, 400 ml normal saline we have given, and the lactate blood culture has been sent out, and the antibiotic. Now I'm going to commence on the patient on the antibiotic. Please store the 1 gram ceftriaxone. We will also pass the urethral catheter and also the urethral catheter. One more point, important. What is that? I verbalized it before.
Urinary catheter.
Okay, urinary catheter.
Urine culture.
And yeah, urine sample. Yeah, you must take the urine sample in central culture. Good. So this you need to verbalize. Okay, and then you go for the reassessment. Then you will go for reassessment, airway, breathing, checking, etc. Then you go for a patient cardiac arrest, follow the Alice protocol. How do you think? Is this good, or the one you already practicing is the good? Which approach is good? You need to ask. I apologize. You need to ask the lactate level after E. You can ask. Even the nurse will give you tell. Do we have the blood result? Do you blood culture or the lactate level? Maybe she will give you. Then you come in on it. But I don't think so. You will get the lactate level insane. So I don't think so. And the chest infection, always do the X-ray. Don't skip it, because you are doing wrong if you are skipping. Also, the ABG is very important for the respiratory system. So you need to go for it. Don't need to wait for the C to go in and do an ABG or VBG. Okay?
Yeah.
So let's go for the hypothermia. So we see that in preparation, you have to start everything in the preparation. The hypothermia going to be stored modified station from the preparation. For example, you need to ask a nurse to prepare for low-grade thermometer, 1 blanket, turn on air conditioner, warm air conditioner, prepare airway equipment, suction, trolley, mechanical CPR device. Now, mechanical CPR devices we use if the patient is coming up from the frozen place like mountains, he went and is frozen. In that case, we need it because we cannot compress manually. That's why we also need mechanical CPR device. And make sure that all equipment should work properly. So make sure that when you verbalize these things, you should do very quick. And the nurse bay prepare the drugs, warm, IV fluids, cardiac monitor, BP cuff, IV access, CV blind defibrillator. Okay, the position is the same. Now, the hypothermia patient, what we know that is come up in cardiac arrest. Okay, but you can have in different ways. It's likely, I don't think so the patient come up in non-cardiac arrest. It's always like the cardiac arrest, so you have to follow it. It's already maybe patient unconscious and maybe no sign of life, maybe have sign and then he go cardiac arrest. Anyway, because they want to test you important things here when the patient is in cardiac arrest. Otherwise, hypothermia station not going the way you think. Okay, please check the temperature. What you have to do is patient arrive. Please check the temperature with low-grade thermometer. That's very important. Okay, why? If you find the temperature is low, remove the wet clothes and apply the warm blankets and heating pads. Please turn on warm air conditioner. Well, even you didn't go for the further means A or the A, I mean airway. So before going to do, you have to say these all things. You need to take initial measure. If the patient alerts, no unconscious, please check the sign of life, look, listen, feel, no sign of life. Okay, now that's mean patient cardiac arrest. Please call the anesthetic ICU team and start the high quality CPR. Attach the back wall mask. Everything the same as we did in previous in overdose cardiac arrest patient, but few things are different. You need to check the rhythm on monitor and you to defibrillation. Okay, first shock should be given. Okay, second shock, then resume the CPR for 2 minutes. Meanwhile, you will go for 4H and 4Ts, the same like as previous station we went. Hypoxia is managed with CPR of oxygen. Patient may be hypovolemic possible. We will see on the monitor. Hypothermia, yes, it's likely because patient temperature is below, which you will know when patient just came in ED and you know what was the temperature. You need to mention. Hyperkalemia, okay. The same way the lab has been sent, lower jugular cannula has been taken this, and here you need to ask about the nurse, could you please help me with the blood sugar level? The nurse will check it for you. Auscultation, the attention method, less likely in this case, we will do the bedside echocardiogram to confirm that thrombosis is less likely, toxin less likely in this patient. So has 2 minutes passed, you will go for second shock and third shock, and then you will ask the nurse what nurse to do.
Check temperature.
Yeah, check the temperature. Very good, excellent. So ask the nurse, could you please check the temperature? And remember one thing: when you finish the T, 4H and 4Ts, here you can ask the nurse, like for example, ask the nurse to give the fluid if required, give the 500 bolus, as I write here. Please continue active and passive rewarming and give 500 bolus from fluid, because patient most likely go hypothermia and hypovolemia too. So that's why we need to go. And 2 minutes passed, first, second shock given, third shock given, and then you have to wait. Here you ask the nurse the temperature. If you found the temperature is low, you need to withhold the drugs, including the how to say this, shock. But you need to continue CPR. But you will say the nurse continue CPR and continue active warming and passive rewarming, including give the humidifier oxygen for core and also the warm fluid to this patient. Okay. So once the patient, the temperature, then you ask the nurse, could you please tell me what's the temperature now after passive and after giving IV fluid, bolus, everything? And the patient say, yeah, the temperature is improving. the temperature is now above 30, then you'll give the adrenaline to the patient every 8 to 6 minutes. Okay, and also give the forced shock if required. And then you need to go for the stabilize the patient, okay, and then go for further the apologize here why I should write you. One second. Then you have to go for the handover to the specialist, or you have to reassess the patient. So this is the protocol in the hypothermia. So did you understand the preparation you need to modify? You also need to modify the management plan, especially when the patient carried about the drugs and the shocks. Clear so far? Do you have any question here?
Yeah.
Excuse me?
Just
Yes,
one
sir.
question
No
here.
question.
Regarding the hypothermia, I will know before I will go inside for the station, or how's the clue regarding the hypothermia?
Yeah, this is a very simple question. Hypothermia drowning, because in this case, they will mention patient has been drowning and he's brought into the ED now.
Drowning is clear, yes, but
Yeah.
there is other case, it will be rather than drowning.
Look, patient is drowning, right? Now what you have to do, you need to check the temperature, right? You have to take, because patient has drawn and you don't know. Right? When you take the temperature, patient is going to have maybe low temperature, right? So you have to take the step following. But if the temperature is fine, then you don't have to go. Just remove the wet clothes and attach the cardiac monitor and install the CPR. You don't understand my points. Is it clear?
I mean, sir, drowning, okay. There is other scenario for hypothermia rather than drowning?
Oh, you're asking about another scenario? Yeah.
Yeah.
Can be many scenarios. Can be patient like come from the frozen place. It was cold winter and this patient has been found on the bench. Now is brought to the ED. They can make the scenario like that. Or the patient has the expedition in the mountains. And then after that, he has been found unresponsive.
So in this scenario, when there is a hint that this is the case for the hypothermia, so we will start with the temperature, or we have to start from ABCDE.
Look, this patient is in cardiac arrest, you see? This patient is where? You guys need to understand, if the patient is cardiac arrest, you need to go for LS protocol. If patient is not in cardiac arrest, then you go for ABCDE. But if in patient is cardiac arrest, you have to go LS protocol, and then you go for reassessment ABCDE. Did you get my points?
If he is not in cardiac arrest, but there is a clue about hypothermia, I should check temperature from the beginning, or I should wait till E?
Temperature, I would say, either in the cardiac arrest, either in there, you need to do initially. But I don't think so. I don't know any station like that is coming before. But if, as you said, it can be likely, so I would say to go for the temperature first, because it will give you an idea that whether the patient need a warm blanket or whether need to maintain the temperature of the environment to provide this patient. You have to do the first, check the temperature. Overall, in both cases, non-cardiac and cardiac arrest. But for the exam, I would say it's not possible that you should have this station is not cardiac arrest, because how they will test the drugs. For example, the modification in hypothermia management is here in when to use the defibrillator, when to not use, and when to give the drugs and when not. So it's less likely you will have the patient in non-cardiac arrest. Clear so far? Overall, yes, I would say both need to be checked the temperature first. Clear?
Okay.
There's one guy, he also asked me. Is it clear now?
Yes, it's clear. So there is no possibility
Yes,
for the
yes, sir,
hypothermia to come as complex station, like to start as hypothermia and then turn to arrest.
It's all the one I knows. I don't know. Even you can check the books as well, but you will not find the hypothermia would come up like non-cardiac arrest. Should be in cardiac arrest. Even it's not cardiac arrest, but approach is the same still. Why? Because the temperature will give you idea whether this patient required the warm environment or not. If the patient came up to drowning, right? You don't take the temperature. Right? So how you will know that he need a warm blanket, he need to remove clothes or not? How? You need to take the temperature, right? So once you check the temperature, then you have to take the further step. So in both cases, it's required to check the temperature first.
So can I sum up that less than 30 degrees, we can only give 3 shock if required. And then
I have written here. Ventricular fibrillation, after third shock, delay further shocks until current temperature is greater than 30 degrees. Okay, you can take the photo with your phone. And one more thing is important, but I don't want to mention for MRCEM is ECL, extracorporeal life support. We also need to, but it's different cases. It's according to European Research Council. So now we don't have found in the UK, but it's not in for you. But for you, this is important that the hypothermia station would be present like that, where either the patient has been brought from the cold winter and he's frozen. Maybe he's brought from the mountain area. He has an expedition in winter time. They will mention like that. And then you can guess this station goes where. Check the temperature, remove the wet clothes, and apply the warm blanket. So all modifications start from the beginning, and the rest of things you will do in shock when you cardiac arrest. So, however, if even they present to non-cardiac arrest patient, eventually it will go to cardiac arrest later on. But I didn't see any station like that. Okay, but you have to be ready for both scenarios. Any question?
No, it is clear. No, I have no question so far.
I think some people ask me hypothermia, sepsis, this is blah, blah. I think for everyone it's clear now. I had to run the station. Overall, I want to make sure that your eye should be look at the monitor if it's connected. You should be communicate with your colleague nicely, forecasting. Could you please help me with that? Could you please do that? Could you please do that? Meanwhile, I will do this assessment. But don't do the way you are doing. What is this? Saturation? What is this? This is not a good way of communication. First of all, it means you are not going the way. That means you are ordering someone do for you, but you're not doing nothing. It would be good that if you say, could you please help me to check the blood sugar level? Meanwhile, I continue my assessment to check his level of consciousness. Or I do neurological assessment. So these, the connector, these sentences you should verbalize by yourself when you practice. Make sure the sepsis, I think the way best to follow the sepsis, the way I showed you just now, follow it is much more important, and you can secure a good score. Okay, thank you for joining everyone. Okay, thank you. So let's come up to the upper GI. I want to give you an idea, then you can think about by yourself. Is like yesterday. So first of all, you read the scenario. So I'm getting to the station now. I would say, hi there, my name is Dr. B. I'm the one of the emergency doctor here today. May I confirm your name and grade and your role, please? Thank you very much. So the nurses now will go to say, hello, yes, doctor, my name is Katie. I'm managing the airway. I am the ALIS provider. The nurse B will say, yeah, I am the Monday. I am the ALIS provider and I'm managing circulation. Okay, then you say, nice to meet you. Thank you very much. And we are expecting, or we have got a pre-alert that 35-year-old male is going to brought in the E-day. So please call the ICU team or the gastroenterologist, maybe patient required, because in scenario they will say upper GI, so you need to verbalize this upper GI bleeding, so likely require endoscopy later. So call as soon as possible, and then you come up to the nurse. Okay, you or Miss Katie, you're managing airways, so please prepare following equipment: suction, oxygen saturation, and also the difficult airway trolley. And apart from that, if required, you need to say to nurse to call the anesthetic in case. Then the C, the same way you say is you're providing, you're managing circulation, please send the pre-alert to blood bank. Patient need require the massive transfusion, and also the equipment, which includes the drugs, for the resus drugs, defibrillator, etc., which are relevant to her. And then you say, okay, put on PPE and wash your hands. Thank you. This is your short briefing you given, okay? And then you go for, okay, please keep in your mind if anything missing, you can edit by yourself, sir. Okay, then you go for is the patient arrive? Okay, is patient is here? Okay, is here. Then you go to over the head of the patient. Okay, then you have to check it. Is the patient conscious or unconscious? You have to verbalize. Now I'm going to assess the patient. Let's follow the ABCD protocol. I'm going for the A. Let's assess the patient right now. Is the patient conscious? The nurse will say is unconscious or is conscious. It's up to her what she reply to you. And then you will say, if she's unconscious, then you will pretend to do like, look, listen, feel. You should know how to do that, okay? You put your head closer to feel, listen, and also feel with your hand to check the pulse. So central pulse, if it's there or not, then you say, okay, there is pulse. The nurse will verbalize behind you. Okay, then you come up to the airway. The airway is, now I'm going for the airway to check the airway is patent or not. The nurse will say, no, there is vomit or etc. And you say, please give me suction, or you have to suction the airway. Thank you very much. You have to suction the airway. And this way you can go the further to B or what else. Then again, you confirm, is the airway patent of this patient? Yeah, it's patent, doctor. Thank you very much. I'm very happy with the airway. Yeah, I'm going to let's move to the breathing. Please, nurse, could you please help me to check the respiratory rate and also the oxygen saturation of this patient? Thank you very much. Meanwhile, I go to check other parameters or going to inspect the patient. And then you need to expose the chest. Now I'm exposing chest and I'm checking for any scar, deformity, etc. And then you say palpation. Now I'm checking the trachea. When you put your finger, then there's a trachea central. Then you check the chest expansion, very quick to go. And then you will go for the percussion and auscultation. So you hear the lung sounds. Of course, if it's sepsis or another relevant, maybe she will say there are crackles, etc. Then you will again verbalize, okay, thank you. I'm happy with the B. The patient saturation is maintaining, is 98%. Respiratory rate is this. Okay. Then you go for, let's move on to C and let's check it out. Could you please help me to check the patient blood pressure and heart rate? Meanwhile, I go for to check the patient's CRT and peripheral pulse. So you will use your hand to check pulse. Maybe nurse will answer to you. And also when you check CRT, use your 2 finger on the sternum. You will know the nurse will say 2 seconds. It's less than 2 or greater than 2. And that can give you an idea. Okay, after that, you say to the nurse, Miss Wendy, could you please help me to pass to large bore cannula extract blood for full blood counts, cross-match, UNEs, the toxicology screen, and what if these things, UNEs and blood culture if required. And then you say, verbalize, okay, we have seen that the patient blood pressure is low, the heart rate is high, and the respiratory rate is higher too. So that's indicate the patient is that is indication of active massive, the massive transfusion. Patient require blood, please activate it. If not yet, thank you. To elder the nurse say, this test you verbalize to generally for everyone, and then you take the further steps. You will go for the, if fluid require, you go for fluid, if required the blood, then you have to go for the blood. For example, you will ask O negative blood. Do we have it? Have it. Okay, please give the O negative blood to this patient right now. And while it's going through, I need to continue my assessment further. So then you will go for the day, and nurse, could you please help me to check the patient glucose level? Meanwhile, I need to go for a neurological assessment of this patient. And then, of course, if patient is conscious, you need to ask a question. If unconscious, then you need to go for GCS, and nurse will verbalize, yeah, the GCS like that. Okay, so then you will check the pupil with your hands. You just pretend that you're checking the pupils, and after that, you have to verbalize. Yeah, the nurse will say the blood glucose level is 7 millimeter. Okay, thank you. The glucose level is this, and the GCS is this. If the GCS is low, etc., you need to call the anesthetic. Similarly, in circulation, again, you need to verbalize that to call the gastroenterologist. Still not yet, because you already said once during starting. The same, you will go for Enos. Could you please help me to check out the patient blood pressure? Meanwhile, I need to check another deformity after complete exposure of this patient. And then you complete exposure and check for deformity. Now I'm checking deformity. Then you verbalize, okay, I haven't found any deformities, and the patient the temperature is this. Okay, so based on my initial assessment, the patient is having the bleeding and patient blood pressure is low. And in this place, you will ask the nurse one question. For example, if the alcoholic is mentioned in the case, is good. If not mentioned, then you can ask the nurse, could you please, is the patient taking any medication? The nurse will say no. Okay, so if the alcoholic, the patient, the case is mentioned, that means it goes to the varicose bleeding. Okay, so you say, so that means the patient is not on any medication. That's and patient has history of alcohol, so likely to be the varicose bleeding. So my next step would be, I would give the patient I'm going to prescribe 1 gram antibiotic and the 2 mg of the terliprosine. And we will use call the gastroenterologist as soon as possible, if not yet. And also please pass the urethral catheter and take the urine sample and send to the laboratory. Okay, meanwhile, I will go for the reassessment of the patient. Make sure that you're not going to hand over patient here, because still you need to stabilize this patient. You haven't done it if you just give all negative, because you still need to go reassessment. So you need to go for reassessment, then airway, everything, then I'm sure you will stuck in circulation again. So here you will ask the primary pack, okay? But make sure that you already verbalize for the blood test result in E after E, so that they should bring it up in C when you reassess. So you will ask, do we have the primary pack? After primary pack, you will ask, do we have the blood result? It can nurse say yes or no. Do we have ABG or etc.? She will say yes or no. And you ask hemoglobin and take the stay accordingly. I think, is it clear so far?
Yes, sir.
I think if you go this way, you will not spending a lot of time, and you will go very fast. Because something you can check on the monitor, when you ask the nurse to do, the nurse will say on monitor, and then you just quickly note and verbalize the points and move forward. Don't waste your time in anything, because when you're asking what is the blood pressure, what is the respiratory rate, it means you're wasting your time. You are asking each question from her. So that's the reason that you are going in trouble. But if you just verbalize it, could you please help me to check the blood pressure of the patient, respiratory rate, the heart rate? Nurse will do it by herself. She will just verbalize, that's it. So not a long time, means 2 questions in 1 time. This can save your time, and you can run the station very concise way and to the point. So this is what you have to do. Okay, there are a few more points. I don't want to make it a lot change. I will do for the newcomers the real time how to run the station. Okay, no problem. So how many of you guys are ready for the role play?
I am ready.
Me?
Okay, great. So the first station, who wants to do? It's in front of you already.
I can do.
Okay, that's great. So I'm going to make it bigger and basic. Okay, start now.
Hello, good evening. I'm Dr. Medina, is registrar. May I confirm your name and grade, please?
Yeah, I'm Katie. I am the LS provider.
Okay. Okay. Nice to meet you. Okay, Kate. We are expecting one patient. He's a 30-year-old. He's found drowning. Okay, let us to prepare ourselves. Please just prepare the airway and take care of airway and prepare the airway to release and prepare the suction and oxygen. Okay, and I want also to prepare this the thermometer, low-grade thermometer, and warm blanket, and prepare warm fluid as well, and alert the ICU team. Okay. We're expecting patient will come in 2 minutes. Let us to wear our PPE and wash our hand, please. Okay.
Okay, doctor.
Thank you. Okay, so patient arrived.
Yeah, patient is here.
Okay. Just first of all, please, because we're expecting patient is drowning. Please, Sister Katie, could you please check temperature? Meanwhile, we will try to remove the clothes for the patient, and just we will warming the AC, and also close the cover the patient with the blanket. I am going to assist the patient as well. Okay. Okay. Hello, sir. Are you okay? I'm assessing the patient. He's alert.
Patient is unconscious.
Okay,
unconscious.
Okay, so look, listen, and feel. I'm checking the pulse and looking for any breathing, any sign of life.
No patient in cardiac arrest, no sign of life.
Okay, Sister Katie, please put the resuscitation team alert and let us to start CPR, high quality CPR, 30 compression by 2 ventilation, please. Okay, okay, and we need just to connect the monitor for the patient. Please, I want to know the rhythm about for the patient. Okay, the rhythm is here. So the patient is VF. I am preparing now as DFib now. I will put in asynchronized mode. Okay, take care of ambu bagging and chest compression is going on. So please stay clear. How much the temperature in the beginning? You didn't tell me. Okay, just I'm shocking.
Yeah, the temperature was 29.
29.
29
okay.
degrees. Yeah.
Okay, so our patient hypothermia. Now our rhythm is showing VF. So I'm going to shock the patient. Okay, just I stand clear, everybody clear, I'm clear. Okay, so I am shocking, shock deliver.
Shock deliver.
Okay, consume the CPR, please. Okay, and let us to revise our 4H and 4Ts. Okay, for hypoxia already. As ventilation is going on, please optimizing the oxygen. For hypovolemia, this patient could be hypovolemia. Sister Katie, could you please just give the patient normal saline, please? Okay. And put please cannula and take blood for full blood count, UNAs, and VBJ as well, okay, and toxicology, okay, because I want to know about the hyper and hypokalemia later, okay, and our temperature already it is low, as a patient most likely it is hypothermia, okay, let us to continue to revising, okay, for T's regarding the pneumothorax. I'm checking the identity now for the patient. It is equally, right?
Yeah.
So it is
lungs feel clear.
Unlikely. Yeah, I want to do the bedside echo to just exclude the cardiac tamponade. Okay?
Yeah.
It is done. It is... Okay,
yeah,
great. No. Okay. So for toxins, we have any history, we have anything relative to the toxins, my team?
No.
Okay, great. So for thrombus, I think we have any history of chest pain or any relative history, so it is unlikely also. So my team, this patient unlikely it is hypothermia. So let us to just continue rewarming, continue high quality CPR, okay, and give the patient a modified oxygen, please, and 2 minutes pass.
Yeah, 2 minutes past.
Okay, so stop and switch and analyze the rhythm now. It's still the rhythm. It is
Same.
VF. Same. How about the temperature?
Temperature is still 29.
Okay, again, I am shocking the patient, okay? Because we have to shock only 3, and we will be sure. Now I'm shocking, okay? Everybody clear, stay clear. So shock deliver.
Shock deliver.
Okay. Yeah, okay, good. So consume the CPR, please, Sister Katie, okay? And take care of Ambubagi.
Yeah, 2 minutes past.
Yeah. Okay, what about our temperature?
Still 29.
Okay, and what about our rhythm?
Is the same?
Same. Okay, so I can give the third shock, okay? Then we will hold the shock, will not give a shock if the temperature it is not greater than 30 and more, okay? And even for drug, we will not start it until to be 30 and more. Okay, so I will give another shock for this patient, okay?
Third
So
shock is delivered.
Okay, great.
Third shock delivered.
Yeah, okay, great. So consume the CPR, okay? And let us to check our rhythm again, okay? Continue rewarming this patient. And again, just our temperature, how much, please?
It's above 30. 31
30.
now.
Okay, 31,
31
great.
now.
Yeah, okay, so my team now we can start with adrenaline. I'll give this patient 1 milligram adrenaline, 1 to 10,000, and repeat it every 5 to 10 minutes, please, okay? And okay, my patient, it is hypothermia. Still, I am rewarming the patient, and I need the ICU team as well, okay? And how about the CPR is going well, right? Okay, just continue the CPR, please, my team. And what about our blood? Any result is there? I want to see hyper and hypokalemia.
No, not yet. 2 minutes past.
Not yet. Okay, so stop, switch, and analyze the rhythm. What about the rhythm now?
Sinus check.
Okay, I will check. I am checking the pulse now. Any pulse is there?
Yeah, there is.
Yeah, great. Our team will achieve the ROSC for this patient. Okay, just we will take the post-ROSC management. Okay, just airway. We need for A and B. Okay, oxygen to be 94 to 98. Okay, and what about the oxygen now? I will reassess my patient.
Yeah, it's 94%.
Okay, good. And what about the blood pressure?
Blood pressure is improved to 160.
Okay, great. And what about our temperature now?
Temperature is 34 or 35.
34, great. Okay, great.
30,
yeah, I am checking the pupil. Is it reactive?
Yeah, they are.
Okay, great. Okay, so ICU team is here. I want to introduce the patient to them. Patient now in the this one, post-ROSC, and I need anesthesia doctor to intubate this patient. And
okay.
Okay. So
Finish. Thank you very much. First of all, you forget about the temperature. You didn't ask me in the beginning before you go for ARA. As I said yesterday, first you ask about the temperature, okay, to check the temperature, and then you go for to ask the nurse to go for rewarming, okay, active and passive. But you have to start first the passive, remove the clothes, okay, you need to verbalize, remove the clothes, check the temperature. Temperature is this one. Okay, so start the turn on the warm air conditioner, this environment. Then you go for A or B or C. Okay, one is this. Another is IV access. You need to take in while you said, please store the high quality CPR, connect to the back wall mask. Okay, and attach the defibrillator page. You need to verbalize. You didn't verbalize that. Okay, and also the defibrillator page. And after that, you need to ask a nurse, please pass the to large bore cannula, extract blood for these all relevant, like full blood count, the UNEs. Those are relevant, so you need to ask to do that. And then once patient got risk, then you need to discuss with team, yeah, this patient came up with hypothermia and we resuscitate him, and now he's got risk, and now let's reassess the patient because you are running out of time. So you need to reassess the patient. Okay, what about the temperature? What about the airway? What about breathing? These all, or even you don't ask about the temperature there, then you should start with the air, right? And in the E, you need to ask about temperature, and then you have to hand over this patient to the relevant specialist. Is it clear?
Yes, yeah.
That means overall means first you need to start with the ALS protocol, ALS approach, and then ABCDE in reassessment. Can you hear me?
Okay. Yeah, I can.
That's great. So you need to be very careful with the temperature. You need to ask in the beginning. Also, you did a good job to ask the temperature when you are going for shock. It's good, but you need to ask it anyway. You need to make your speed a little bit faster. I gave you 1 more minute, but it's still the station is running, so you need to verbalize very fast and avoid the irrelevant things, which are relevant. Like you said, post-risk is not your job to do, but you need to call the anesthetic in advance. This patient needs it. Then you need to, so you don't have to comment on the post-risk, the management. You need to just only, once you got the risk, go for reassess. Yeah, that's it. If you don't have time, don't waste on the post-risk management. Okay, well done. Great job. So next station we are going to have is, who wants to do next station? There was someone who wants to do this station.
Yeah, me. Firas.
Okay, let's go for the next station.
Dr. B, just one question concerning the last question. The first one, the first case. Do we have to talk about immobilization of cervical spine since the patient was drowning in a canal, or no need to mention about it?
It's can be possible if do you have trauma, if they mention anything like that, but I don't think so. It's required. Actually, they want to check your hypothermia management. This is not the ATL station, so it's less likely. Yeah, yes. But if they give you like this, the patient has jumped in the canal or any other place. That means likely patient have the injury. Otherwise, no need.
Okay. So it's a 72-year-old patient about to arrive, having collapsed in the street. He had a history of
Ready?
Yes. Yeah, hello, I'm Dr. Akoum, Emergency Registrar. May I confirm your name and level, please?
Yeah, I'm Katie. I am the Alice provider nurse here.
Nice to meet you, Katie. Katie, we are expecting to receive one patient that collapsed in the street. Are you comfortable to take care of the airway? Prepare just the airway trolley, and if you can please also prepare the circulation, some IV cannula, and some fluid. Okay, let's wear our PPE and wash our hands.
Okay.
So, thank you. So, patient here?
The patient is here.
Yeah. So, hi. Hello, sir. I'm Dr. Akoum, Emergency Registrar.
Patient is unconscious.
Okay. Look, listen, and feel any chest movement, any pulse while checking pulse?
Yeah, there is a sign of life. Patient is...
Okay. So please, Katie, please, can you help me just put the monitor on the patient's leads and blood pressure and pulse oximeter, and let's get an ECG for the patient.
Yeah, it's here.
Yeah. So on the monitor, we have complete heart block. So Katie, can you please help me to get the heart rate, the saturation of the patient?
Yeah, the patient oxygen saturation is the 84%.
Yeah, so please, can you just apply non-rebreather mask 15 liters per minute? I'm checking his chest. Is there anything on auscultation?
Okay, supplied.
Yeah. So as we said, so the patient is having a complete heart block. So can we please, Katie, insert two IV lines, two large bore IV lines, and start to give the patient 0.5 milligram atropine. And let's take also blood for full blood count, UNE, VBGs, and cardiac enzymes, please. Do we have any thing from the family or any endorsement from the ambulance?
No.
Okay, great. So we'll just repeat the atropine 0.5 every 2 minutes up to 3 minutes. So I will continue the assessment of the patient. I will check the capillary fill time.
Okay.
1,
it's 2,
2, 3,
2,
4,
2
5.
seconds.
Okay, great. Yeah, great. So let's start also normal saline 500 cc over 15 minutes. I will continue my circulation. Anything in the abdomen?
It's fine. There's no any scar mark.
Yeah. So Katie, can we check the blood sugar while I'm checking the pupils of the patient? Pupils reactive to light?
Yeah, reactive. And blood glucose level is 5.
Yeah. Okay, great. So let's recap and reassess the patient. How's the airway now? Still patent?
Patent.
Great. So what about the saturation now on oxygen?
94%.
Great. I'm happy with the saturation. What about the heart rate? Still the same, 37?
The heart rate is the same here.
Yeah. Blood pressure?
Blood pressure is low, 90/50.
Yeah. So Katie, I believe the patient he's still in shock. So let's give him another 0.5 milligram atropine.
Given.
Yeah, and let's prepare also in case isoclonine, in case it didn't improve, and let's also inform our colleagues from the cardiology team.
Okay. Yes.
Okay, so I will continue the assessment. Is the patient able to move his limbs, or
patient condition is the same. the hot black and the low blood pressure.
Yeah. Yeah. What about the temperature?
Temperature is 36.5.
Okay, great. So I would recap. Oxygen still fine.
Yeah, 94%.
Yeah. Great. What about the heart rate now?
Heart rate is low also.
37. So we'll give another also atropine until 3 milligram.
Yeah, it's given already 3 milligram, as you said, repeated every 5 minutes. So
Yeah.
it's given.
Yeah. So let's prepare to give the patient isoprenoline 5 microgram per minute IV infusion.
Patient doesn't have CVP line.
No, I asked for yeah. So we'll just put a central line. Then we'll start for him isoprenoline 5 microgram per minute per hour.
You know, they insert the line is central CVP line now.
Yeah. So we'll just do transcutaneous pacing for the patient. I will put the pads. Then we have to give him midazolam 3 milligram IV. If you can please help me having the midas, and I will So I put on the pacer mode and will put 70 as heart rate, and I will start to increase the current until I reach an electrical capture. So in the first one we don't have. In the second one I have electrical capture.
Yeah, there is electrical capture now.
Yeah, with 140. Can I have just? Can we just recheck with the patient? How is his blood pressure? How is his saturation now?
Saturated 94%, and blood pressure is improved to 160.
Yeah, great. So thank you so much, Katie. I think the patient now he's stable to go to the cardiology to the CCU. So let's inform our team in the cardiology team. The patient need transvenous pacing. So we'll endorse him to the cardiology team.
Okay.
Thank you.
Recorded the chain. The patient is hand over. Thank you.
Yeah.
Okay.
So,
what's your name, doctor?
Firas. Firas.
Okay, that's good. Great job. Well done. But the way of your approach is upside down, I would say. You need to be very, very careful what you need to ask in A, what you need to ask in B. So you skip many things. For example, you go in A, when I say the patient is unconscious, but there is sign of life, then you ask the nurse, could you please apply the high flow oxygen or 15 liter with a non-respirator mask, okay? And then you come up to, let's move, I'm very grateful with the A. Now let's move to the B. Nurse, could you please help me to check the saturation and respiratory rate of this patient? Meanwhile, I check another parameter of this patient. And you go for inspection, palpation, and then I comment on that. And after that, you come in circulation. And here in circulation, you should get this slide, which I showed just now, this one. And you find it at this, then you have to comment on this slide here. I see in a monitor, the patient is in hot black. So what we have to do, we have to, first you go for IV access, and then you go for the finding, explain finding, like hot block, then intervention. You will ask the nurse, could you please give the atropine 500 microgram and repeat it every 5 minutes to maximum 3 mg. Apart from that, please apply the pacing pace or defibrillator pace, because all defibrillator has the pacer mode too. So you need to verbalize, and meanwhile, you need to continue. And also the low blood pressure, also give the bolus 500 ml normal saline. Thank you. I'm very happy. And let's move to the day. And now I'm going for neurological assessment. Nurse, could you please help me to check the patient blood pressure? the blood sugar level, and then she will check it, and while you finish the GCS, and then she will comment, yeah, the GCS this one, then you check the people reactive, then you go for E. Nurse, could you help me to check out the patient blood pressure, etc. Then reassess, and reassess, you will stuck again in they say, and then here you're gonna go for the pacing. But one more important thing you forget is, okay, this patient is unconscious, okay? But if the patient is conscious, what important point should we aid in this station? Anyone can tell me.
Conscious sedation.
That's great. Conscious sedation. So what is the conscious sedation means? What, anyone can tell me what's meant by conscious sedation?
We have to give him sedative and analgesic. Analgesia and sedation.
Yeah, means the patient would be conscious but no pain. He would be comfortable.
Yeah.
This means the conscious sedation. So this can be mild, can be moderate. The minimum requirement is resuscitation for that. You need a sedationist, you need the ALS nurse, and you need one more doctor. If it's no, you can go ahead. So these are common in mild drugs. We give the midazolam and fentanyl. So this kit along with that sometimes. So this is how we do. And another important point was what this was, isoprenoline. I said yesterday in a webinar that for that need a CVP line. So you need to skip. Before going reassessment, you say that the patient has a bradycardia, and we already give the atropine 3-mg. The second line drugs would be the acerbrolane, but we have to go for the CVP line for that. But so that's why we are not going. So we are going for the transcutaneous. Transcutaneous pacing. That's what. But you need to worry about. If you don't worry about, no any problem that. Okay. So this could be verbalized. It means discussion could be done after E. I always say you take some time, few seconds, maybe 1 to 2, 30 seconds to give initial assessment, okay? Try to give a little bit explanation of initial assessment, what you have found and what you have done, and then go for reassessment. This can give you the score in your point because you already finished the initial assessment, right? So if you explain, even the station is finished, you're still gonna get your score. So there's not really need to worry about that. Okay, great, fantastic. But you need to...
Can I ask one question? Actually,
yes.
Do you think that in this scenario, is it relevant to ask that the patient is, since this is a case of the bradycardia, then the patient is on any medication like beta blocker or something so that we can proceed for glucagon? And second thing about the risk factors for the patient has asystole or something, so that just I'm asking about this.
Okay, let's about the drugs. The drugs, as I said, some points you can aid in the E, but in this case, did they mention there the patient has any heart condition? So you can ask about the beta blocker, but I don't think so is really likely to be here. They want to test you. What is your approach on the bradycardia? Overall, your first approach would be the atropine, right? Whatever he is on a beta blocker or not, but your approach still will be the atropine. So see, in the initial assessment, you will go for atropine. That's what I said in the after E, you need to verbalize. Like as I said in GI bleeding when I said, you need to ask the nurse is the patient is on any medication or not. That means that indicates maybe he is on NSAID. That's why he has upper GI bleed. Can be possible, right? Maybe in the background of that, in case the alcoholic is not given. So this way you can rule out. If that's what I say to aid the explanation a bit after E would help you to know more about, and you can cover everything which is relevant. Good to ask. If you don't ask, no any problem at all. They want to test you overall in transcutaneous pacing. How you go for transcutaneous pacing? that you know about it, or do you have any information almost? They want to test you there. But it's good point to ask about beta blocker. It's good if patient has a heart condition. If no heart condition is not mentioned, you can skip. Okay, any other question with relevant to this station?
Yeah, and my second point is to consider the risk of deterioration, like risk of asystole. Should we ask to consider pacing?
The risk of asystole is, as I said to you, all the station either go with the pacing, either they want to test it there, or they will say the patient is unconscious, is already unconscious, but there are no sign of life as well. So you need to go for ALS approach. Again, it's toward the high quality CPR. That's what they can make it, the station like that. Okay, so the risk of asystole can be avoided with the atropine. That's why we give this. These are 4 criteria for that. That's why we give atropine. But as you said, the patient would go in SSLA or anything like that. That means in cardiac arrest. So of course you will start the ALS approach. I mean, start the high quality CPR. You will go for the connect to the back wall mask, etc. And this way you can go and check the shockable rhythm or unshockable. That's been the ALS approach. But here now, just now we discussed it's not inpatient, it's not in cardiac arrest. Is it clear, or is it a little bit complex for you to understand?
Yes, thank you.
Your question was that, right? To avoid the risk of asystole, right? That was your question. Or your question is that the patient would go in asystole and then what intervention should be? Was that your question?
No, just we need to ask to verbalize to inform the examiner that we are considering the risk of asystole also.
No. It doesn't require it because this itself is a risk of asystole already in a heart block. So it will be, so it's obvious. So you don't have to verbalize. Okay. Okay. Any other? Any lady, she was asking one question. I don't know who was there.
Yes, I wanted to ask with regards to conscious sedation. This patient was unconscious. Are we supposed to give the midazolam?
No, he's unconscious. If he's conscious, he needs to be midazolam before you go for transcutaneous pacing or any defibrillator intervention. Okay.
Here, Dr. B, we have a patient. I have one question.
So many questions. I will give you a chance in the end. Okay. Thank you.
Okay.
Okay. So who wants to practice next station? Anyone?
I will do it also if no one.
Your name is Shiraz, right? Shiraz.
No, it's Fira. No, it's Firas. F-I-R-A-S.
Sorry. Okay, any other station other than these 2 candidates?
I can. Yes, I can go for it.
Okay, so there is a lady, new voice, I think, so she can
do it.
Sir. Okay. This is the case.
Yes, sir. Let me start.
1 second.
Hello, I'm Dr. MRCEM. I'm one of the senior doctors working in emergency department. Can you please tell me your name and your position and the role?
Yeah, I'm the KTM ALS provider and I manage airways.
Okay, nice to meet you. Okay, now we have received the pre-alert that we have a patient who just collapsed and who had palpitations, and that patient we brought, and she's 30 years old. So we also need to call the cardiologist. You can manage airway and circulation both?
Yeah, there is another nurse. She will manage. You just pretend.
Okay, let's make sure that we are all wearing PPE. Okay, so I just want you to prepare the trolley. Just have all the equipment ready. And please have the cardiac monitor, UP cuff, and the sedative drugs. Be prepared to maintain the IV access and defibrillator. Okay. So in this, now the patient is coming in. I'll be the leader. Has the patient arrived?
Arrived. Patient is here, doctor.
Okay. Is the patient alert?
Yeah, patient is unconscious.
Okay, the patient is unconscious. Okay. Now I'll just look, listen, and feel. The airway. I'm checking the airway. Is it patent?
Yeah, patient is sign of life, and the airway is patent.
Airway is patent. Okay. Can you please apply high flow oxygen by a non-rebreathable mask?
Okay.
Thank you. Can you please connect the cardiac monitor while I check other parameters?
Okay.
And can you please tell me what the saturation is?
Yeah, patient saturation is 94% on oxygen.
Okay, and what is the respiratory rate?
Respiratory rate is 19.
Okay. Now I'll just auscultate the chest. I'll just and I will also auscultate for the heart sound after exposing the patient. Okay, I'm inspecting the patient, doing palpation, percussion, and auscultating. Is there any finding that I need to know?
No. It's normal.
Okay.
Lungs fill up there.
Okay, now I'm going to circulation. So the heart rate is very, very high. The patient is tachycardic at 208, and the patient has SVT. I'll be checking the CRT on the sternum. Can you please maintain IV access?
CRT is here.
CRT.
Mm.
Okay, how is the CRT?
2.
Okay. Kindly please insert 2 large IV cannulas and send blood for full blood count, BVGs, UNEs, and toxicology strains as soon as possible.
Yeah, yeah, it's done.
And I will also need an ECG strip.
Yeah, Dr. ECG is here.
Okay, let me analyze it more clearly. Okay, it seems that the patient has SVT. Okay. Now, what can you please tell me the blood pressure again?
Yeah, blood pressure is patient is the low, not very high. It's around the 90/60.
Okay. Can you please also send call to the cardiologist? Now we'll give the patient 500 ml normal saline bolus. Okay. And are there any adverse features present?
Yeah, this blood pressure is low is an adverse feature.
Okay. Can you kindly please attach the defibrillator pads and to the patient? And we'll have to give shock to the patient. Okay. Attached. Okay. What is the rhythm? Now we need to give the shock. Everyone, please clear and please deliver the shock.
Shock deliver. How much shock do we need to give?
We need to give 150 joules of shock.
Okay, it's given.
Okay, now how is the patient now?
It's still same.
Still same. Okay. Now the rhythm is still the same, no improvement?
No.
Okay, now we'll have to deliver another shock. Please check the rhythm and give another shock. Delivered. Now how is the patient?
Still same.
Still same. Okay. Now we'll have to give third shock.
Third shock is given.
How is the patient?
Is sinus tachy.
Sinus tachy. Okay, now that's very good. I'm really happy with that. He did not have to do for them later on. Okay, I would like to do the reassessment now. So how is the patient's airway?
You want to do reassessment? Yeah, patient airway is patent.
Okay. No, sorry. I would like to I would check the patient's GCS and the pupils. How are the pupils? Can you please tell me?
Reactive.
Reactive. Okay. And I would also like to check the patient's BSR, blood glucose.
Is 5 millimole.
Yeah, and the rhythm is normal now. Okay. Now I would like to reassess the airways patent.
Airways patent.
Breathing is normal. Circulation is good.
The patient blood pressure is 100 by 60 now.
By 60 now. That's great. Okay. Has the cardiac team been has the cardiac team been informed?
Informed. They are soon arrive.
Okay. I'm very happy with the condition of the patient. Thank you very much. We did good.
Okay. What do you think, guys? This show you this strip is in front of you. This rhythm is what is it?
Tachycardia.
Yeah, that's correct. It's ventricular tachycardia. So I want to make it in cardiac arrest later on because I give you this patient as unconscious. Otherwise, I would go for the conscious, and then you should go for the conscious sedation. But I want to make it in cardiac arrest in your reassessment, but I found that you are struggling with this station. So I just make it simple and you end up here. Excellent, good job. Overall, you did very well. But I would say this strip is, first of all, there are two kinds of things can happen in the exam. One, either they will put the monitor in front of you that it shows you everything there. Another, maybe they have the strip in their hand. A nurse will take it from the table and give it to you. This is a strip. So both can be possible. You should be ready for both of them. So here I put on the monitor because most of the time they show on monitor. In before 2021, since the guideline has been changed, I mean, not guideline, but the RCAM criteria of the examination a little bit changed, as the research was very important at that time, the mandatory stations. So in that time, they usually give on the form of strip, and nurse can give you in your hand. But in this case now, they don't do that. I didn't hear it about they are doing that, but can possible. You should be ready for both of them. Another thing, you should little bit study the cardiac monitor and defibrillator, how to recognize the rhythm. You need to a little bit practice if you have time. If you don't have, no problem. Okay, so the doctor, I don't know, I think Dr. Mariam, right? So you forget E, you didn't ask about E, okay? And you didn't recognize the rhythm correctly. So this is also one of the points. In case, I want to ask you guys, in case if it is SVT, what could be your intervention?
Again, the question.
Regarding treatment, adenosine first.
If
vagal maneuver.
Vagal maneuver, yeah. Yes. If it is the SVT, you need to go for vagal maneuver. If it's not, then you have to.
Dr. B, as this patient in STEM, it can collapse. So that one we can consider as a reverse fixer and go for the shock immediately.
Patient is unconscious. And the patient blood pressure is low. So in that case, this adverse feature. Any tachyarrhythmia, if patient has adverse feature, go for shock. Okay. I'm talking about in SVT also including, but any patient, any tachyarrhythmia, a patient has adverse feature, you need to go for shock. Okay.
Yeah.
If patient
patient
is not in no any adverse feature. if no any other risk feature, then you have to go for relevant treatment like amiodarone in monomorphic. So let's go for the next station. Who wants to do this station, guys?
Can I do it?
Okay, that's great. Are you ready?
Yes. Hello, I'm Dr. Ham, one of you, doctor. Can I confirm your name and level, please?
Yeah, I am Katie. I am the LS provider, and I manage the airway.
Okay, nice to meet you, Katie. We are expecting to receive a 30-year-old male who was taking amoxicillin and came with rash. Are you happy to deal with airway?
Yeah, very well.
Okay, please prepare airway thoroughly oxygen suction machine. Also, I would like to prepare for me, please, circulation. Are you happy to prepare that? Please prepare cardiac monitor, pulse oximeter, and IV line for access for him. Okay, let's wash our hand and our PPE.
Okay.
Okay, I would like to assess the airway by checking responsiveness of patient. Hello, sir. How are you?
Yeah, patient is talking. Yes, I'm okay.
Hello, Mr. Yes, I'm Riham, and this is my team. I will take care for you. If you don't mind, I will be able to examine you. It's okay?
Okay.
Okay, I would like to assess his mouth. Can you open for your mouth for me, please?
Okay.
I see for any tongue swelling, any abnormality in his mouth.
No.
Okay. So Miss Katie, kindly for me attach his for oxygen high flow, so 50 liters to non-basal mass. I will adjust it later. Now I am happy with airway. I will shift it to breathing. Please, Katie, connected our patient to monitor, cardiac monitor, pulse oximeter, blood pressure cuff. Also by inspection, any abnormality in the chest?
Rash all over his body.
Okay, regarding chest rising bilaterally?
Yes.
Okay, I use chest expansion.
Expansion is normal.
Trachea?
Is central.
Okay, auscultation. Any added sound?
Yeah, there is some wheezing on his chest, lung sounds.
Okay, okay. Regarding heart sound?
Heart sounds are normal.
Okay, so Katie, dismissed properly with anaphylaxis. Please connect him to salbutamol, 1 milligram and 5 ml. Okay.
Okay.
Okay, and now I'm happy with breathing. I move to circulation. I check capillary filling time. For me, please check the blood pressure and pulse. Capillary filling time 1 to 4.
Blood pressure is 90 by 40.
It is the hypotensive. Pulse, rate, rhythm, volume.
Yeah, pulse is tachy.
Okay, rhythm, the sinus tachy in our monitor. Okay, so most probably we dealing with anaphylaxis shock. Please, Katie, put bilateral large bore IV cannula, extract blood for urea electrolyte, CBC, cross matching, triptate, and also give him fluid. 500 ml normal saline. Please call for me the ICU team for him. Please give him atropine 0.5 500 milligram anterior mid thigh for him.
Atropine, Dr. Atropine or adrenaline?
Adrenaline, sorry, adrenaline.
Okay.
Okay. Yes, and prepare the next dose when there's no improvement after 5 minutes. Now I will continue my assessment. I go to D. What about DCS for our patient?
Yeah, patient is conscious.
Is it okay? Pupil reactivity and light for bilaterally.
Equally reactive. Equally reactive.
Okay. Okay. Can you take for me glucose for our patient?
It's 5 millimole, doctor.
Okay, good, great. Thank you. Please, can you expose patient? I will cover you later. Sorry, sir. I will expose your body. Sorry for you. I will expose. I look for any rashes, any deformities.
No. Rash all over body.
Okay. Regarding the temperature, what is it?
Yeah, temperature is 36.8.
Okay. Okay. So I will reassess my patient airway. It's still patent.
Patent.
80
patient.
in high flow oxygen.
Yeah, 94%.
Please call Katie for me. Please call the anesthesia. This patient may be made intubation because there is maybe compromise his airways.
Doctor, patient is talking. Why needs intubation?
I mean just prepare because he's 80 now. He's 80. I am afraid.
Not 94%.
Okay, sorry. It's yes, okay. It's a good. Ignore my calling to intubation for him, and is an 94. Okay. It's a good breathing bilaterally. Wheezing is still wheezing bilaterally. Like chest.
Okay. Yeah.
Saturation.
Patient is unconscious now, doctor.
Hello, sir. Any sign of life?
No sign of life.
Please, Katie, call the resus team and we'll start the chest compression about 30 to 2. Please push hard, push fast, ambubag through ventilation by ambubagging, connected with high flow oxygen, and give a first dose of adrenaline. So let's revise our 4H and 4Ts regarding hypoxia. Patient now in oxygen, any resistance by ambubagging?
No.
Okay.
2 minutes passed.
Okay. Please can reassess and check the rules. Shift the rule and reassess the patient.
Yeah, patient is sinus taking now.
Sinus live. Then there is pulse.
Yeah.
Okay. So we achieve ROSC. I would like to endorse my patient to ICU.
ICU team is there.
Okay, hello, I'm Dr. Riham. Today we are receiving this patient. He came with anaphylaxis shock. He has inpatient cardiac arrest. We do CPR in hospital. One cycle patient retain. First dose of adrenaline is given. Second dose. Now he's preparing for infusion for your kind care. Regarding ABCDE, patient mostly need intubation. Fluid running, temperature normal, other no availability for your kind care, please. Thank you.
Okay, thank you very much. Good job. You did very well, but the problem is the patient is conscious, no need oxygen. Okay, patient is talking.
Yes.
I said talking, right? The problem is patient. His problem is circulation. That's the anaphylaxis, not wheezing. Wheezing cannot help you in B. Because I said the airway is okay, right? In B, you hear the wheezing, but it's not really likely the patient really is going to anaphylaxis unless when I say the blood pressure is low. That's indicate you more that patient is anaphylaxis. So you need to go for the first dose and you ask the nurse to prepare second dose. Okay, second dose you give in the reassessment, and I say it is still then you ask for infusion. But if it would be better if you said to give the first dose and also give the second, you need to mention the place where you need to give the first dose. You didn't, did you tell about the where you need to give the first dose and how to give?
Yes, side, yes.
Okay, okay, that's
Mid
good.
side until lateral, yes.
Excellent. And also you should say they repeat the dose after 5 minutes if the patient is
5
going.
minutes.
Then in E, you need to say in my initial assessment, the patient, I found the patient is anaphylaxis, the first dose isn't given, and the second dose, ask the nurse if it's given or not, because you said repeat after 5 minutes. She given or not? If she doesn't given, that means to ask her to prepare for the infusion. Or you can ask about the prepare for infusion in, say, after giving first dose. She should say we also prepare for second dose, because this station depends. If you find the anaphylaxis in airway, then obviously you need to give second dose, maybe in C. But if you found in C first dose given the second dose, you might give in reassessment, or you ask the nurse to repeat after that, and also ask her in that same place to prepare for the infusion. Okay, so when in case I would say, for example, I give you another approach. For example, you forget to say that to prepare for infusion. You give the first dose, and when you come up reassessment, you give the second dose, and you give second dose, and now you don't know what to say. For example, you give second dose, but she didn't prepare for the infusion. So you should ask her, is the infusion is ready for the adrenaline for this patient? Patient is verbalized. First, what you will verbalize, dear nurse, the patient is in refractory anaphylaxis now. We need to give patient the adrenaline infusion. Is it ready or not? The nurse say, no, ready. That means, okay, please continue the adrenaline, give every 5 minutes. Okay, I am, till the infusion is ready. So this can protect you from every side. You still can get 10. Okay, this is another approach. If in case infusion, you didn't say NC to be ready, or because you need to make the thing concise. If you didn't give the first dose, and you even still didn't give second dose, so it would be not logical to say like prepare for infusion, because you still have choice to give second dose, right? So you should think about it when you run station. Anyway, great job. You did very well, but your communication still need to be a little bit better if you could make it. For example, I'm going for neurological assessment. Could you please help me to check the blood sugar level? That would be better, and say to ask what is the blood sugar level, because you didn't say how to check it. Once you ask her to check, then you ask her what is the blood sugar level. That makes sense. Okay, great job and well done. I made it in cardiac arrest because I believe that likely anaphylaxis will go cardiac arrest in yours in the exam. Mostly it goes cardiac arrest later on after 2 doses. Okay, so who wants to do next station?
Yes, I can.
Okay.
Okay, 60-year male, arriving upper geriatric procedure with facility while having a part of like more than 14 minutes experience in 2 minutes. Okay, hello. Can I start? Okay. Hello, my name is Dr. Zishan. I'm a senior registrar in the ED. Could you please introduce you and your level of competency, please?
Yeah, I am the Casey, and I am the LS provider, and I manage the airway.
Thank you very much. Actually, we received a call, a pre-alert, a 60-year-old male. He is about to come. He has hematemesis, bloody vomiting, and he is alcoholic also. So I want you to please wear PPE. I want to assign you one of them. One of you will manage the airway, the other one will manage the circulation, and the third one will manage the defibrillation. Are you confident with it?
Okay.
Okay. I want also you to call the gastroenterology and the anesthesia, as a patient may require intubation later on also. So I want one of the nurse in the meantime to prepare the equipment like suction, oxygen, and trolley, and make sure all the equipment work properly. The other nurse will prepare the drug, cardiac monitor, and IV access, hemorrhagic trolley, major hemorrhagic defibrillation, and also activate the massive transfusion protocol and the blood bank. So I am going to stand. Okay, is the patient all right?
All right, patient is here.
Okay, right. Is the patient is an alert, conscious?
Patient is unconscious.
Okay, is there any sign of life? Okay, can I see, look, listen, and feel? I will feel it. I will feel, look, listen, and feel. Is there any sign of life?
Your patient has sign of life. Patient has pulse.
Right. Okay, so I would like to start from the A, B, C, D, E. So let's, is the airway patent? After suction, actually, after suction, I want to say that after suction, we did the head-to-general maneuver, and we put the rebreathing mask 15 liter with the high flow oxygen. So please connect the cardiac monitor and the probe saturation. Could you please tell me the oxygen saturation and the respiratory rate, please?
The oxygen saturation is 94%, and respiratory rate is the 25.
Right. Okay. How is the lung fields and the heart sound, please?
Sounds
please
clear.
help me? Okay. Now please
Clear.
expose the chest. I will do the inspection, and in the inspection, okay, what is the how's the inspection?
Inspection is there is no any deformity or any rash.
Okay. In the palpation, what is the trachea central?
Central.
Okay. What is the expansion of the chest?
Normal.
Okay. And how is the percussion? Is there any note percussion pelvis?
No.
Okay. In the auscultation, is there any added sound?
No, it's normal.
Okay. And the heart sounds are also normal?
Yes, it's clear.
Okay. I will move to the circulation. How is the BP and the heart rate, please?
Yeah, patient blood pressure is 90/40, and the heart rate is 120.
Okay. What is the capillary refill time also?
Is more than 3.
Right. So patient is in the most likely in the shock also. So I would like to intervene, that put the please 2 large bore cannula and extract the blood for the full blood count, VBG, UME, cross match, and the toxicology screen. And okay, I would like to give the transdynamic acid. And I would like to activate the major transfusion protocol. If you can give the O negative blood to this patient, and also
how many
you can
units?
give the 4 negative, 4 units of the blood.
Oh yeah. Okay.
Okay, and I want to also please give the transdynamic acid 1 gram in 10 minutes.
Okay.
Okay, I would like to also call the gastroenterology for the endoscopy in case of the variceal bleeding. And since the patient is alcoholic, I would like to give the terlipressin 2 milligram, as well as the antibiotic ceftriaxone 2 gram.
Okay.
So also please insert the NG tube and the urinary catheter. So how is the BP now?
Still same.
Okay, right. I would like to move to the disability. How much is the glucose level?
Glucose level is 5 millimole.
Okay, it's okay. How is the conscious level still?
The patient is unconscious.
Right. Okay. What is the pupillary light reflex now?
Reactive.
Okay. So patient is still unconscious. I would like to intervene that since the GC is below 8, I would like to intervene. Already we have called the anesthesia. Are they here? In the meantime, I would like to check the exposure of the patient. Is there any rash? Please expose the patient. Is there any rash or swelling?
There's no deformity.
Okay. What is the temperature,
rash.
please?
Temperature is 36.8.
Okay, right. So we have activated the major massive transfusion protocol also. So okay, I would like to reassess the patient. How is the airway now?
Airway is patent.
Okay, how much is the saturation now?
94% on oxygen.
Okay, BP now?
BP is 90/60, 90/40.
It's still low.
So
okay.
same.
So please transfuse the primary pack, what we have advised you, and please check the monitor and do the VBG, and please you can prepare the secondary pack also if there is any blood result came out, like in case of the platelets. Okay, not yet.
Doctor, primary pack. Yeah, primary pack is given. The blood results are this one. You can check it. The hemoglobin is 6.
Yeah, if the hemoglobin is low, we will give the packed RBCs. We'll give the 4 unit, and the FFP are low. We will give the what is low? Fibrinogen is low, so we'll give the FFPs also 4 units. So I would like to know the conscious level. Is still patient unconscious?
Patient is unconscious.
And no sign of life, right?
There is sign of life, and blood pressure is improved a bit.
Okay, that's good. That's wonderful. So I would, is the anesthesia is here to intubate the patient, or I want to know the gastroenterologist is here now for the endoscopy or not yet?
The gastroenterologist will be arrived soon.
Okay, right. So we have given I would like to recall that we have given the terlipressin, we have activated the major transfusion protocol, and we have taken all the bloods for toxicology, everything, and we have given the primary pack already. And now
Doctor,
the patient is improving.
Yeah, gastroenterologist is here now.
Right. So I would like to transfer my case to the gastroenterologist. Doctor, I have this case, 6-year-old male, alcoholic, with the hematemesis, and we have stabilized the patient. We have given the packed, we have given the primary pack, and now the patient is improving. Please, I would like to you to please do the endoscopy as soon as possible to create the hemostasis. Thank you, sir.
Right. Regarding your station, yeah, some I would consider interruption, so it's a little bit went different way. Anyway, you did a great job, but remember that once you give the O negative bloods, then you need to move to the D and A and reassess, and here you need to stuck long time because you need to give first primary pack and then you have to go secondary pack. And about the result, you need to say and say that please make the result as soon as possible. We will need it. You also didn't ask about I think you forget about the heart rate. I think maybe. So what you have to do, you need to aid these everything before you move to asking the reassessment. Another thing is about antibiotic and the telepricing. Would be better you add in E. As I say, the C is relevant to cardiovascular system, not with it's nothing to do with the improvement of cardiovascular if you add the antibiotics. So antibiotics and the urinary catheter and also the telepricing would be better to 8 and E. And one more thing you forget to ask about any medication patient is taking, like an NSAID, it would be also the case. Right. It's said is patient is on alcohol, but it doesn't confirm that patient is in alcoholic disease. So if you rule out the drugs, that's likely be alcoholic disease. So in this could be the varicella. So you need to go for antibiotics. So these few points you need to put in your mind, and I believe that the practice will make you perfect. And so do practice as much as you can with your colleagues and a little bit faster. Okay, so next station, who wants to do? Anyone? Is there anyone who wants to do the next station?
I can do it.
Okay, if the newcomer should do it, okay. This is the station for you.
Okay.
Start? Or you want to read the scenario?
Sorry. Again?
You want to check? Okay. Here you are.
The scenario.
Yeah, it's here.
Okay, I'm ready. Okay. Hello, Nace. I am Dr. Nelly. I'm working in the ED today. May I know your name, your qualification, please, and your ALS status?
Okay, yeah, I am Katie. I am ALS provider, and I manage the airways.
Okay, I have a pre-alert that we are receiving a 63-year-old male who's unwell. That's all we know for now. So I'll ask you, please, if you can prepare the airway trolley and make sure all the equipment is working properly. I'll help you with preparing the circulatory trolley. Is that okay? In the meantime, as we wait for the patient, if we can just wash our hands and put on our PPEs, please.
Okay.
Okay, has the patient arrived?
Patient arrived?
Okay, hello, sir. I'm Dr. Nelly. Is the patient responding?
Yeah, patient is confused.
Patient is responding?
Yeah, patient is confused. He's conscious. Yeah.
Okay, any stride on the voice?
My name is Andy. Yeah. I'm patient. Just
okay,
acting like.
Okay, Henry, I'm Dr. Nelly. I'm here to take care of you. Okay, his airway is heightened. Patient is responding. I'll just quickly go to the breathing. So please, nurse, can you help me get the monitoring equipment, pulse oximeter, BP, ECG? I'll just quickly expose his chest and examine him. Hello, Henry. I'll just quickly look at your chest. Is that okay?
Okay.
Okay, so is any distended neck veins?
No.
Any chest deformities, scars? Okay, Henry, no. I'll just quickly touch you to chest to check for any to see how your chest is moving. Please, nurse, can you quickly help me with his oxygen saturations and his respiratory rate as I palpate and auscultate his chest? Is that okay?
Yeah, is oxygen saturation 85%. The respiratory
95?
rate is 85%, 85%, and the respiratory rate is 30.
Okay, the oxygen saturation is quite low, so please, nurse, can you help me with connecting the non-rebreather mask and put it as 15 liters per minute, please? Thank you. Okay, so Henry, I'll just quickly percuss your chest. Is that okay? Percussion, not?
No, normal.
I'll just quickly auscultate your chest. Is that okay? Auscultating the chest.
Yeah, there was a like crackle on the left side of the lungs of the base.
Okay, so we have crackles on the right side of the face. So we most likely look like our patient might have a pneumonia. It's okay, I'll quickly get back to that. We can now move to circulation. Our oxygen is running. The blood pressure.
Yeah, so blood pressure is 90/50.
Okay, sister, if you can help me with his heart rate as well.
It's on the monitor. Tachy.
Okay, so
Sinus
he's
tachy.
okay. Our patient has a sinus tachycardia with blood pressure which is quite low. Sister, kindly help me get 2 IV large bore cannulas. If we can get fluids running about 500 liters, we'll assess after some time, please. Capillary refill time.
Capillary refill time greater than 2.
Okay, so our circulation, we're good. We've got our fluid running. We have a sinus tachycardia, nothing remarkable on the heart. All right, thank you. Okay, if we can also get blood, sister, as we put the IV line for full blood count, CRP, cardiac enzymes, blood culture, and everything. Okay, thank you. So just quickly move to disability. Sister, as I check for his neurological status, I'll kindly ask you if you can help me with his blood glucose levels, please.
Okay.
Okay. His pupils.
Yeah, reactive.
How are his pupils? What about
reactive?
His GCS scope? His GCS
The patient
scope?
is a bit confused.
Okay, so sister, what about his blood pressure? Have you managed to check his blood glucose levels?
Yeah, it's 5 millimole.
Okay, so we are good to go. So our patient has a low GCS. Okay, we'll just quickly move to exposure. I'll quickly expose our patient. Okay, so Henry, I'll just quickly expose to take a look at your body for anything, any rashes, any bleeding.
No, there is no swelling, no any scar or any swelling or rash.
Any pallor, any jaundice, anything on the abdomen?
No.
Any edema on the legs?
No, normal.
Okay, so our patient, a nurse looks like our patient has sepsis, secondary to a pneumonia. I'll just quickly ask you if you can ring ICU so that we can take the patient to ICU. So our patient has septic shock secondary to pneumonia. So in the meantime, we have our oxygen running, we have our fluids running. I'll ask that we get ceftriaxone so that we can give our patient. I'll just quickly reassess the ABCs as well. So just further confirm if there's any other foci of infection. I'll ask that we do a chest x-ray. We already have our bloods for full blood count, CRP, ABGs, electrolytes, cardiac enzymes.
Yeah, we have the...
I'll also ask that we put a catheter. Is that okay?
Okay.
So Henry, will just quickly put a catheter.
Here is the result of lactate level.
How are his lactate levels?
It's elevated.
Elevated. Okay, do we has our first 500 mils finished running?
Yeah.
Okay, so how is our BP now?
Yeah, BP is a little bit improved, 160 now.
Okay, so our BP is better now. So we can quickly get in a catheter to check our urine output. So I'll quickly reassess the patient as we await for the ICU team to arrive.
Okay.
So Henry, I think you have sepsis. So you have what we call a pneumonia. You have an infection in your chest. So we'll just quickly take you to ICU for further management. And in the meantime, we'll put you on some drugs that fight infection. Is that okay, Mr. Henry?
All right.
So quickly reassess the patient. How is our saturation now?
Saturation is 94%.
Okay, our saturation is good. Our blood pressure?
Blood pressure is 160.
Okay, so our patient is good to go to ICU. Thank you.
Okay. Now, the one thing is very important that I would say initial assessment is good to go, but the later you need to go for reassessment. Okay, suddenly. You don't have to stay there. When you discuss this another thing is in B you said the patient is crackle and likely pneumonia. You don't have to say pneumonia because you still didn't confirm the diagnosis. You're supposed to say patient has a chest infection, maybe due to due to that he has a crackles, and then in the B you need to order the X-ray and ABG to check out. In ABG, when you check out, you need to comment is type 1 failure likely to see, and maybe you can also see the lactate level in B. Okay, you will comment the patient is metabolic acidosis. That might be due to lactate, high lactate. So when you got the result in lactate in after E, and then you can comment here, it's confirmed the patient is in sepsis due to the chest infection, and it's likely pneumonia. And after that, you would say to go for to pass the catheter and send the urine sample. Meanwhile, I continue to reassess this patient. Then you go for airway, you go for B. I don't have to make it comfortable, this patient, the patient blood pressure improve, but I did it just, you should hand over this patient to the ICU for further management. So overall, you did very well in initial assessment, but you took a lot of time while you're staying in after E. So that don't do that. And X-ray in ABD should be done in B, would be better. And after soon discussion, and you don't need to confirm diagnosis in B because you don't know. You didn't see the chest X-ray. You haven't seen the lactate level. So you don't have to confirm the diagnosis until you don't see them. Okay. In the exam, in real time, nurses want to see you what step you need to take. As I said, the breathing step you need to take in the breathing. Means if it's relevant, you take intervention like X-ray and ABG to check a type 1 failure. And the C says you need to give the fluid. You did very well. Good job. You did it. In E, you did also very good. And also the antibiotics you did in after E. That's great. Fantastic. I appreciate it. So you continue to do that, but don't take a lot of time. And a lactate level should be asked in that place, or when you go for reassessment, maybe you get the lactate in that time. Okay, well done. Next, who wants to do the station?
Do we need to verbalize sepsis 6 word?
Yeah, excellent. Yes. This must be verbalized. Yeah, I did it in yesterday. I forget to repeat it again here. Yeah, you need to verbalize. We have to follow 6 sepsis protocol. We have given oxygen already. We have to give the fluid 500 bolus already because you already gone from C, right? And then you come up to the antibiotics that we have sent lactate level and blood culture. You already did it in C. Because these verbalize after E, right? So you verbalize the 6 sepsis, and then you say, now I'm going to prescribe antibiotic, which is very important in 6 sepsis protocol. So you verbalize, and urine culture you have to send in after catheter. Okay, great job. Well done, everyone. Because if you don't verbalize, you will lose some score. So because doctor want to say the examiner that you know about the 6 sepsis protocol. Anyway, thank you to remind me, and it's a good thing that it's also for everyone. Okay, so next station, who wants to practice?
Yeah, can I?
Who wants to do? Have you done again before station, or is your first time?
I've done before. Yeah.
Okay, any other candidate who wants to do the first time? Know anyone? Okay, let's start the one who already. Okay, let's start from you first, and then the doctor. I don't know what his name. It's Sean, right? I don't know.
Yes,
probably. Okay, let's go to lady doctor first. Okay.
Okay. Okay, hello, I am Dr. Medina Edi Registrar. May I confirm your name and level, please?
Yeah, I'm a KT and I'm LS provider, and I do manage the airway.
Okay, great. Alice, we are expecting one patient collapse in street, and he will arrive soon. Okay, just prepare the airway thoroughly, and just alert the ICU team, and just we need help another nurse to take care of circulation. Okay, and prepare our equipment for circulation and monitor and defib as well. Okay, and let us to wear our PPE and wash our hand. Patient is here.
Yeah, patient is here.
Okay. Hello, sir. Are you okay? I'm going to assess the patient now.
Patient
Okay.
is unconscious.
Okay. Just look, listen, and feel. I'm looking for the pulse. I am checking the pulse, looking for any breathing.
No pulse, no sign of life.
Okay. So my team, this is patient in cardiac arrest. Please alert resuscitation team and start CPR compression, high quality CPR, third compression, and 2 ventilation, please, by back valve mask. Okay, and connect the monitor. I want to see the result. Okay, and please, sister, just insert the white bore cannula. Take blood for full blood count, UNAs, urea, this one, UNAs, and toxicology as well, and VBG as well. Okay, I want to see the monitor now. Okay, monitor is here. Okay, so I can see there is a VTAC, ventricular tachycardia with pulse rates. I want to just to show to this patient. Okay, just I will put the bags. Okay, just I will put the defib in 150 joule. Everybody clear? Stay clear. Okay, I want to shock the patient. Shock the liver. Okay. So just let us to revise.
Shock given.
Shock given. Okay. So just continue CPR, please, and let us to revise for H140s. For hypoxia, you have any system in ambubagi, or it is good, sister? Hello.
Yeah.
You can. Yeah. Okay. And
Yes,
for hypovolemia, please.
I found this box of some medication, doctor. Can you see it?
His voice is not clear. What's the medicine you found?
I found this medication of the drugs, doctor.
Yeah, okay. What's the drug name? I cannot see.
Yeah, these are Deltizin.
Okay. So this is a patient. It could be overdose of calcium channel blocker. Okay. We need to give the patient calcium chloride. Okay. Just give the patient calcium chloride, and just let us to continue to revise for HM40s. Blood send already, right?
Yeah, blood sense.
Okay, great. Just I want to know about the temperature for the patient, please, for hypothermia.
Yeah, 36.8.
Okay, great. Regarding the T's, I am waiting for the result for hypokalemia. For the T's, for pneumothorax, just I will auscultate the chest, airways in the bilateral equal.
Equal.
Okay, good. For tamponade, I want to do bedside echo. Okay, it's negative or?
Yeah, it's fine.
So,
there is no tamponade.
Okay. Yeah, so unlikely. Regarding the this one thrombosis, any history there for the patient?
No.
Okay, so my team must likely our patient on cardiac arrest due to overdose of calcium channel blocker. Okay, already calcium chloride given to the patient.
Yeah, patient is given how much? Yeah, we have given 10% NM.
Yeah, okay, 10% and 10 ml. Okay, and now, okay, continue CBR and just 2 minutes pass.
Yeah, 2 minutes pass.
Okay, so stop, switch and analyze the rhythm. Okay,
it's
what
same.
about the same?
Still
Okay,
same.
yeah, okay. Again, I want to shock this patient. Just prepare the shock now. Okay, everybody clear, stay clear. So shock deliver.
Deliver.
Yeah, continue CBR, please. And just for the patient, I want to give also high dose of insulin. Okay, and VBG is there.
No, not yet.
Not yet. Okay. So just continue our CBR, and okay. So we can give also okay. We can give glucagon to the patient.
Has 2 minutes passed?
Okay. So stop. Switch and analyze the rhythm. What's the rhythm on the monitor?
Still same.
Same. Okay. Again, I will check the patient. Okay. So okay. Shock deliver and continue CBR. And okay, calcium chloride. We can give also calcium gluconate to the patient.
Yeah, but you need to give the drug, the cardiac drug here. The amiodarone, adrenaline of the third shock.
Yeah, third shock given. Yes, yes, I have to give the patient 300 amiodarone and 1 milligram of adrenaline as well.
Given.
Okay, great. 2 minutes pass.
Pass.
Okay, so stop, switch, analyze the rhythm. What about the rhythm now?
Sinus tachyc.
Okay, I will check the pulse. Any pulse is there?
There is sign of life.
Okay, great. So we achieved the ROSC. Okay, I will assess my patient now. Okay, what about the airway for the patient? It is patent.
Patent.
Okay, great. This one, oxygen saturation.
Oxygen saturation is 94%.
Okay, good. And what about respiratory rate?
Respiratory rate is 20.
Okay, blood pressure.
Blood pressure is improving, 120 by 60.
Okay. Okay, great. So what about the this one pupils? It is equally active.
Reactive.
Okay, and random blood sugar, glucose.
5 millimole.
Okay, good. So I want to just endorse this patient for ICU team.
Okay.
Okay, they are here.
Yeah, they are.
Okay. Yes. Hello, I'm Dr. Medina. I received this patient. He came on cardiac arrest, and he was on shock rhythm, and we found a bottle of calcium channel blocker. He was most likely drug overdose, so the antidote for calcium channel blocker done, and after now patient on AROS under your care. Thank you.
All right. Thank you. Great job. Well done. You have done very well. But again, first you need to finish 4 HN4 chase, then need intervention, go for the antidote. Another thing is that you're forgetting the ALS protocol. It will going on continuous. Like you need to give the research drug, the ALS protocol, which we use it. Okay. So yes. don't get confused. You just continue, give third choke and then continue this protocol because you have to follow that. However, to avoid the reversible causes, you need to give antidote, calcium chloride, calcium gluconate, and also the insulin with the glucose. That's good. Yes, you have to, but don't forget about the drugs which we use for the resuscitation in ALS approach. Yeah. Okay, so it's very important. Otherwise, and little go faster. You did very well overall, but you again a little bit confused. Anyway, no problem. You will have more minutes in 8 minutes, and you will go, and the actor will be more professional. and the monitor will be in front of you. Everything will be visible very well, and you can quickly read and go over to the next. Okay, so let me see if we have one more station or it's over. I'm not sure that I can check it out. No more station. Oh yeah.
There'll be just a question on the previous monitor.
About the previous
the monitor, just a picture of the monitor.
Okay, you want to check the monitor? Okay.
And so it looks like the two different readings. The green ones looks like the speed tag. The other one looks like polymorphic.
These are just a sample to taken out from somewhere. It's not necessary you will have like that, but when you will in real time, your rhythm will be visible on defibrillator, okay, monitor. It will be very clear and very obvious. One rhythm even, not 2, 3, only one. So you don't have to worry about that they are different. This is just an example. You should focus on monitor. If the nurse one time says you need to focus on monitor, that means you have to do on that next time too. Okay.
Dr. B, I would like to ask in this scenario where we came, actually I missed that where, at which point we came to know that this is a beta blocker toxicity.
A calcium channel blocker toxicity, right? You're asking.
Sorry.
Okay. Now look. Very, this is a good question and you will know it. Look, when you come up to the 4H and 4Ts, that's what last time in a previous diet, I stress out. If you don't go for 4H and 4Ts, believe me, you will run this station blindly. You don't know what is the cause. Okay, so this is why I say to you, you must go with the 4H and 4Ts each step by step. For example, how you will know the blood pressure, how you will know the temperature is not the cause, because you will go for one point like hypothermia. You will ask the nurse check the temperature, then you have to rule out. For tension pneumothorax, you will do the auscultation to rule out. So if you don't go for 4H and 4Ts, you will not know. So when you will go for 4H and 4Ts, in that place, the nurse will come up to you and say, "Doctor, I found this medication with this patient." Then you understand what medication are there. They will be beta blocker, they will be TCA, they can be the calcium channel blocker. So you have to do intervention accordingly. Clear?
So this 4H and 4Ts will come after the first cycle?
Yes, after you give the shock. When you give the first shock and then you ask the nurse to resume the CPR for 2 minutes, then you will go for 4H and 4Ts. Similarly, when if it is non-shockable, the same. Resume CPR for 2 minutes, and when she will go for 2 minutes, then you will go for 4H and 4Ts. If you don't verbalize 4H and 4Ts, that means you lose your score, because this station is short, not very long station. If you follow the approach smoothly, then you can finish this station within 7 minutes.
Thank you, Dr. B. You have mentioned very important point. Thank you.
Yeah, so remember, if patient in cardiac arrest, you need to follow this one. If patient is not cardiac arrest, then you will know about this, what drug patient has taken in C. For example, when you are going to check the rhythm, when you ask the nurse to heart rate and you see this is bradycardia, in that time the nurse will come up to show you I have found this medication with this patient, but it's less likely. The station usually come with the patient in cardiac arrest with overdose. Less likely, maybe TCA can come up with that cardiac arrest. The most important task, the MRCEM usually give this station with cardiac arrest because they want to test you according to algorithm, that how you go with the 4H and 4Ts, do you rule out or not? So this is how could be done these all things. Clear so far? Any question here?
Yes, doctor. Regarding airway adjunct, can I put it if the patient is unconscious?
About what? What's your question?
Airway adjunct, or pharyngeal or nasopharyngeal. If my patient is unconscious or confused, can I ask for him or not?
Look. can be taken step like this way. For example, okay, in cardiac arrest, you did a back wall mask. That time you have to say about the anesthetic, because when patient got the risk, obviously he needs to go to the further management, and it should require the intubation. So you have to verbalize when the patient is in the cardiac arrest, just to verbalize after back wall masking. You ask the nurse to call the anesthetic so that that patient should require intubation later. So in a non-cardiac arrest patient, for example, in GI bleeding, you did a suction, and after suction, you ask the nurse, is the airway patent? She said no. Then you ask the nurse, okay, could you please do your head chin lift the maneuver? Now, what about the airway now? Is a patent or not patent? And if it's still not patent, then you will go for for example, it's still conscious, then you can go for the oropharyngeal, or you can go nasopharyngeal, for example, in anaphylaxis. Now, in anaphylaxis, the patient is unconscious, okay, and there is swelling of tongue. Now you tell me, will you go for the oropharyngeal airway, or you will go for nasopharyngeal airway in this case?
Nasopharyngeal.
Yes, that's correct. So, for example, this is what I want. Actually, in the exam, this is less likely to come up like that. This usually come like what airway you need to use, oropharyngeal, nasopharyngeal. It's common procedure skills like this. For example, they said there's a patient, he has a seizure just now 5 minutes before, but now not. And now they will not mention now he doesn't have the seizure. They will mention 5 minutes ago. So you automatically, you need to think patient has a seizure 5 minutes before. That means the patient is not seizing right now. So in procedure skill, they will say assess and manage the. They will ask you to manage the airway. So when you come up to the station, so you need to pick up the first. They will mention that you need to pick up the equipment and what equipment you require, and then you need to manage airway. So this is a procedure skill station. Only need to manage airway. In that time, you will start from oropharyngeal airway. You will try to use the measure the size, okay, oropharyngeal from the mandible of the angle into the mouth, and then you try from incisor. Then you try to insert it. If you're not inserting, okay, if you insert it, even you insert it, and then you use the back wall mask to check. You will ask the nurse to check the saturation improve or the respiratory rate. How about the sounds? Maybe nurse will say no, not equal, not very. There is no rising in chest. In this case, you will go for which airway? Then you will go supraglottic airway, right? So they will test you how you start, how you manage the airway. For example, oropharyngeal is failed, then you go for supraglottic. If supraglottic is failed, that means this is like the difficult airway management, I would say. So it's tested in procedure skill. But in resus, it's less likely they will really test you because you don't have time. So they will make about the airway very simple. Either they will just, you go for a chin lift, they will say, now airway is patent, just apply half oxygen. But in anaphylaxis, likely they will give you this kind of scenario, and you should be ready. I want to, I forget this 8-2 point. Thank you very much for reminding me. So, for example, in anaphylaxis, you ask the nurse, is the airway patent? She said, no, there is swollen tongue, there is swollen lip, etc. So that indicates you to airway is not patent, and you need to take a step. What step you will take it? You need to nasopharyngeal airway, right? Then airway can be patent, and you can apply half oxygen.
So in this scenario, can we go for the intubation if in case of the anaphylaxis?
No. You need to verbalize that. Even you ask that you want to do, they will ask you no. In that case, you don't need to go intubation, but you can go for back wall mask. Okay. You need to go for back wall mask. If respiratory rate is not improving, then you need to go for back wall mask.
But in case of anaphylaxis, actually it is mentioned that we have to intubate patient early so that patient may not deteriorate. So that is the reason.
Yeah, that they mentioned, but you cannot intubate the patient. You need to call the anesthetic. in case required, but I don't think so. You will have this station. They will test you overall at the nasopharyngeal. That's it. In research, they will, in anaphylaxis, they're likely to test you with the nasopharyngeal airway, that if the swollen tongue, everything, so that means what your next step would be nasopharyngeal airway. They want to test you, and they will give you score, at least 4 score, just because of this point. If you don't do that, then less likely you'll get the point. So it means you're stuck in A, so how you can manage B or C or D. Okay, so that's very, very important. Any other question?
Thank you, sir.
Thank you so much, Dr. B.
Okay, so no question, everyone, right? Thank you very much for joining.